Good morning, everyone. Here I am present my paper on topic a prospective interventional study to study the changes in intraocular pressure after phacoemulsification in patients with cataract and primary angle closure suspect primary angle closure or primary angle closure glaucoma. Introduction. Primary angle closure glaucoma affects 15 million people worldwide approximately and is responsible for half of the all glaucoma blindness. Prevalence of occludable angle in Asia is 10.2%. A thick crystalline lens may lead to angle closure through reduction in the anterior chamber depth and narrowing of the angle. Studies have reported that IOP control and angle opening after phacoemulsification in primary angle closure glaucoma. Cataract surgery can independently lower IOP, which may allow for greater IOP control among patients with coexisting cataract and glaucoma. Phacoemulsification has been shown to be effective in refractory cases of acute angle closure as well as in eye with control attacks. In a randomized clinical trial, compared with laser peripheral iridectomy, lens extraction resulted in a wider angle, anterior chamber angle, and a deeper angle and lower IOP in primary angle closure suspect eyes. Cataract surgery may be safe alternative to glaucoma surgery in some patients and could shift to a surgeon approach in treatment of concurrent cataract and glaucoma. This study is to evaluate efficacy of phacoemulsification surgery in reduction of IOP in primary angle closure patients. Aim and objective. Aim to study the change in IOP after phacoemulsification in patient with cataract and primary angle closure suspect, primary angle closure and primary angle closure glaucoma. Objective. Visual outcome in patient with glaucoma after cataract surgery. Material and methods. This study is a prospective, comparative, and interventional study. 50 eyes with primary angle closure suspect, primary angle closure, or in primary angle closure glaucoma with cataract at SMS Hospital from May 2023 to August 2023 were taken. Inclusion criteria: patients aged 50 to 70 years with IOP more than 22 mmHg on 2 or more sittings with glaucoma suspect and angle closure on gonioscopy. Willing to provide written informed consent. Exclusion criteria: history of prior ocular surgery and peripheral iridectomy, history of prior ocular trauma and other ocular pathology likely to affect structure and function of angle of eye. Glaucomatous optic atrophy in affected patients. All patients presenting to SMS Hospital with suspected or confirmed primary angle closure glaucoma underwent detailed history and ocular examination. The following evaluation were done in each case, like personal data, patient's name, age, sex, address, registration number. History includes past history or any laser treatment or surgeries and any history of trauma. Best corrected visual acuity, both distant and near. Detailed anterior segment examination on slit lamp with grading of cataract. Intraocular tension with non-contact tonometer at baseline, 1 week, 1 month, and 3 months after cataract surgery. Fundus examination using indirect ophthalmoscope. Axial length, anterior chamber depth by A scan. B scan in case where fundus is not visible. Keratometry, A scan for axial length, IL power calculation, angle visualization by gonioscopy, and grading by Schaeffer's grading system. And after detailed explanation and written informed consent, patient enrolled under study. Result and observation. 50 eyes were diagnosed as any form of angle closure glaucoma along with cataract and underwent phacoemulsification surgery. Results indicate significant mean difference in change of IOP across 3 time period with p-value less than 0.05. Distribution of patients by gender. Out of 50 patients, 23 were male and 27 female. Preoperatively, 26 patients had visual acuity 6/6 to 6/18. 13 patients had BCVA 6/18 to 6/60, and 11 patients had less than 6/60. Post-operative, 46 patients had best corrected visual acuity in between 6/6 to 6/18. 4 patients had 6/18 to 6/60, and none of them is less than 6/60. Preoperatively, mean IOP is 25.5 with standard deviation 8.71. Post-operatively, at 1 week, mean IOP was 16.3, and 4 weeks, mean IOP was 14.1, and 3 months, mean IOP was 14.6 mmHg. Discussion: phacoemulsification surgery alone in patient with any form of angle closure glaucoma with cataract can cause significant mean reduction in IOP. Min Kyung Song et al. Perform a retrospective observational study which includes 77 eyes from patients with primary angular suspect primary angular and primary angular glaucoma who underwent lens extraction and were followed for more than 2 years after surgery, and conclude lens extraction achieved significant IOP reduction. In majority of patients are female. And according to Romskan et al., compared with laser peripheral iodectomy, lens sections resulted in wider and deeper angle. Dennis et al. Performed a prospective randomized controlled trial with 62 subjects to receive either early phacoemulsification or laser PI after aborting primary angular closure by medication, in which early phaco appeared to be more effective in preventing IOP rise than peripheral iodectomy. Conclusion: phacoemulsification for the treatment of primary angular glaucoma along with cataract effectively reduces the intraocular pressure and improves their visual acuity level. So phaco is now considered as one of the first line treatment for patients with all type of angular glaucoma along with cataract. Early phacoemulsification with intraocular lens implantation resulted in reduction in IOP, IOP and number of glaucoma medication. Some are references. Thank you.
Thank you, doctor, for your nice talk. Please collect your certificate from Dr. Kamal Sera. Next speaker, Dr. Arun Kumar Samar. Hello, Dr. Maina. कौन सा है?
A study of systemic factor affecting diabetic retinopathy in type 2 diabetes mellitus patient. The prevalence is 18% in an urban population with diabetes mellitus in India. Duration is the strongest predictor for diabetic retinopathy. Hypertension has higher prevalence in diabetes mellitus subject. It altered hemodynamic by impaired autoregulation and hyperperfusion of retinal microvascular system. It upregulates the VEGF expression. Obesity is also a risk factor for vascular disease. WHO defined obesity when BMI is more than 25 kg per meter square. Hyperlipidemia causes endothelial dysfunction due to a reduced bioavailability of nitric oxide. Endothelial dysfunction causes retinal exudate formation. It might contribute to macular edema. Hyperglycemia and HbA1c level. HbA1c is a biomarker for monitoring glycemic control. The higher HbA1c causes PDR. Materials and method. The study was conducted on 50 patients of diabetic type 2 were presented to or were referred to the Department of Ophthalmology, RNT Medical College, Udaipur. The inclusion criteria was diabetes patient in the age group of 40 to 75 years. Exclusion criteria was patient with type 1 diabetes mellitus, patient with vitreoretinal degeneration and dystrophies, active infection or patient having ocular disease like hazy media and uveitis, patient with retinal disease like retinal vascular occlusion or retinitis pigmentosa. A general physical examination was done. Complete ophthalmological examination was done. Vision was assessed using illuminated Snellen's chart. Fundus examination was done in a dark room with indirect ophthalmoscope and slit lamp biomicroscopy with 78D lens. OCT was done. Fundus photograph were taken. Participants were segregated into two categories: Group 0 with diabetic retinopathy of any stage, Group 1 without diabetic retinopathy. For grading the severity of retinopathy, early treatment of diabetic retinopathy study ETDRS protocol was used. Blood sugar and HbA1c was measured. Diabetes mellitus type 2 defined when fasting blood sugar more than or equal to 126 mg per deciliter or 2 hour postprandial glucose more than or equal to 200 mg per deciliter or a random plasma glucose more than or equal to 200 mg per deciliter. Poor control of diabetes defined when HbA1c level more than 7%. Weight and height was measured. BMI calculated by dividing weight with height in meter square. Blood pressure was measured with manual sphygmomanometer. Two measurement was recorded for both systolic and diastolic blood pressure and average calculated. Hypertension considered for systolic blood pressure more than 140 and diastolic more than 90 mm of Hg. Okay. Results: mean duration of diabetes mellitus among retinopathy subject were higher and difference was statistically significant. Mean HbA1c level was higher among retinopathy group and difference was statistically significant. Mean systolic blood pressure among retinopathy subject was higher and the difference was statistically significant, and no significant difference in diastolic blood pressure was found. Mean lipid level among retinopathy subject was not significantly different than subject without retinopathy. Mean body mass index among retinopathy subject was not statistically significant than subject without retinopathy. These are the data we calculated in our study. Discussion: the average duration of diabetes mellitus in subject with diabetic retinopathy was 9.7 years with a standard deviation of 5.7. The average duration of diabetes mellitus in subject without diabetic retinopathy was 7.01 years with a standard deviation of 4.9. It was statistically significant. The average level of HbA1c in subject with diabetic retinopathy was 9.6 gram per deciliter with a standard deviation of 1.6. The average level of HbA1c in a subject without diabetic retinopathy was 8.1 with a standard deviation of 1.2. It was statistically significant. The mean systolic blood pressure in diabetes mellitus with diabetic retinopathy is 133 with a standard deviation of 15. The mean systolic blood pressure in subject without diabetic retinopathy is 127 with a standard deviation of 18. This difference was statistically significant. The mean diastolic blood pressure with diabetic retinopathy is 80 with a standard deviation of 9, and the mean diastolic blood pressure without diabetic retinopathy is 79 with a standard deviation of 10. This result was statistically not significant. The mean BMI in the retinopathy group was 23.6 kg per meter square and non-retinopathy group was 23.67. This difference was not statistically significant. Dyslipidemia when serum triglyceride level more than 150, total cholesterol more than 160, LDL more than 100 and HDL less than 40. The mean level of triglyceride and LDL was higher and the serum total cholesterol and HDL level in the retinopathy group was lower. None of the above results were statistically significant. Conclusion: keeping blood sugar level HbA1c less than 7%, BP less than 140/90 and lipid level cholesterol less than 200, LDL less than 100 and triglyceride less than 150 under control would be beneficial. Lifelong periodic annual retinal examination is important. Screening facilities for diabetic retinopathy should be available for all people with diabetes to increase compliance. Collaborative effort between diabetologists, ophthalmologists and dietitians are the need of all to help and improve quality of life. Thank you.
Thank you, Dr. Maina. Any question from audience? Please collect your certificate from Dr. Jakhar. Next speaker, Dr. Manvi.
Good morning. Myself Manvi is going to present on an observational study of visual outcome and complications of phacoemulsification surgeries in various types of senile cataract at Tertiary Eye Care Center. Phacoemulsification was introduced by Kalman in 1967, is one of the most important innovations in ophthalmology. It has now been accepted as the gold standard surgical procedure for management of cataract. The goal of this study was to know the complications during and after phacoemulsification surgery and visual outcome in different types of senile cataract. As you can see in the picture, the steps of phacoemulsification surgeries. In the first picture, initial incision was made, foldable IOL is inserted in the lens and that is placed, and IOL is well placed in the last picture. First, the material and method. Inclusion criteria: the patient having senile cataract are subjected to phacoemulsification and patient age 45 and above. And we excluded the patient below the age of 45 having pre-existing glaucoma, corneal diseases, retinal diseases, having pseudoexfoliation syndrome, patient having a history of traumatic events. The observational study was done on 100 patients suffering from senile cataract scheduled to undergo phacoemulsification surgery. Any complication like corneal edema, posterior capsular rupture with and without vitreous loss, zonular dehiscence, retained and dropped lens matter, wound burn, dropped nucleus, Descemet membrane detachment were noted. Data collected includes age, sex, type of senile cataract, preoperative and postoperative Best corrected visual acuity, intraocular pressure, intraoperative and postoperative complication followed up was done till 30 days postoperatively. There is a video of phacoemulsification surgeries being conducted in JLN Medical College. And the IOL has been transplanted. In the demographic characteristics, according to the age distribution, 50 to 60 years, there were 28 patients, 61 to 70, 29 patients were there, 71 to 80, 33 patients, and more than 80, there were 10 patients. Types of senile cataract. In NS1 grade, there were 25% of patients, NS2 43%, NS3 15, NS4 9, and in mature cataract, there were 8% of patients. According to the complication, as we can see in the table, the most common complication is PCR, noted in 2 patients having NS1 grade cataract with early PSC and NS4. Corneal edema was noted in 1 patient having mature cataract. CCC related complication is noted in intermittent cataract in 1 patient. Wound burn was noted in 1 patient having mature cataract. DMD, nucleus drop, endophthalmitis, such complication are not noted. Result. Out of 100 cases, 37% were male, 63% were female. Among the complications, posterior capsular rent was most common, followed by corneal edema, CCC-related complications, and wound burn. BCVA improvement of 98.5% is significant with value of P less than 0.001% paired proportion test. Good outcome was achieved in 53.5%. In day 1, 85.5% at day 3, 91.3% at 7th day, and 98.5% cases at 38th day post-surgical respectively. All the surgeries were performed by single surgeon. In the picture, the above picture, there is PCR noted, and in the below picture, corneal edema was noted after the surgery. Discussion. With the development of phacoemulsification technology, the improvement of surgical techniques and standardization of post-operative treatment has occurred. Phacoemulsification has become the first-line treatment for cataract. The greater the hardness of the lens nucleus, the stronger the ultrasonic energy was used, which leads to increased incidence of intra- and post-operative complication. Conclusion. Phacoemulsification is safe and effective procedure with good visual outcome if performed in experienced hand. Thank you.
Thank you, Dr. Mohanami. Any question? Please collect your certificate from Dr. Kamal Sehra. Next speaker, Dr. Narendra Kumar.
Good morning, everyone. I am here to present knowledge, attitude, and practice about eye donation among general population attending IOPD at tertiary healthcare center. There is no financial support and sponsorship. Introduction. Eyesight is very important for human life. The WHO estimate that for every 5 seconds someone goes blind. Corneal disease constitutes a significant cause of visual impairment and blindness in the developing world. Though there has been progress in eye donation, only 70,000 eyes were collected from March 22 to March 23. As per 2020 research study, globally 4.33 crore are estimated to be blind. 2022 global research reported that 1 cornea for every 70 corneal recipient is available. We would need 2.7 lakh donor eyes to perform the 1 lakh corneal transplantation in a year in India. Soliciting for actual eye donation at the time of family death is a necessary and accepted practice. Raising the level of public education on eye donation is an important first step. Attitude toward eye donation have received more attention in the developing world compared to the developing world. Aims and objective. The purpose of this study to spread awareness for eye donation among the general population attending IOPD at tertiary eye care hospital. Material and methods. Knowledge is defined if the participant understood the use of donated eyes. Attitude are defined as personal views, opinion, and feeling on eye donation, corneal transplantation. Practice is defined by the participant who have heard about eye donation and are willing to place for eye donation. Inclusion and exclusion criteria. Inclusion criteria: patient attending IOPD of all age group who are willing to give informed consent. Exclusion criteria: patient who are not willing to be part of study. The data was collected by the questionnaire method from general population attending IOPD. Questions were administered in local language. We also collected demographic detail from respondent, including age, gender, and education. This is questionnaire. Result: source of information: out of 1000, around 60% source of information by media, 24% by doctors, and 14% from others. 70% people are aware about the eye donation. 62% knows that eye can be donated after death. 52% knows ideal time for donating eyes is within 6 hours after death. 51% participant knows that during transplantation, cornea of the donated eye is used for transplantation. 43% knows that the eye can be removed at donor's house itself. 57% believe that eye donation caused disfiguration of face of the donor. 84% knows not charged to donate eyes. 69% believed medical illness is contraindication like diabetes and hypertension. 64% knows no age limit for eye donation. 43% knows about prior permission for retrieval. 59% knows about the eye bank facility. Attitude regarding eye donation: 90% population believe it's a service to mankind. 45% said against their religious belief. 25% population said spectacles users cannot donate. 52% people with cataract and glaucoma cannot donate, and 16% believe in the myths. Discussion: corneal transplantation offers the potential for sight restoration through those who are blind from corneal disease. Corneal transplantation depend on the people willing to place their eyes for donation. There is a comparison between our study and the previous study about awareness about the eye donation, awareness by the media, eye retrieval at diseased house, eye can be donated after death, disfiguration of the face. There is a great need to educate the population in all fields, particularly those in the medical profession, regarding eye donation, to enable the younger generation to act as future motivator for enhancing eye donation rates. Strategies that have worked well in other parts of the world may be useful here too. Conclusion: the finding of the study show overall knowledge regarding eye donation among population was good. However, the attitude and practice show mixed response. Effective measures should be taken to educate people with relevant information with the involvement of media, doctors, and religious scholars. Thank you.
You can collect your certificate from Dr. Malmani. Next speaker is Dr. Nathuram. Dr. Nathuram. Dr. Nidhi.
Good morning to all. I will be presenting on evaluating maintenance of mydriasis in patients with senile cataract during small incision cataract surgery, a double-blind randomized study comparing preoperative Nepafenac 0.1% and Flurbiprofen 0.3%. Introduction. In the developed world, the primary method for cataract surgery is phacoemulsification. However, in many developing countries where cataracts are a major cause of blindness, phacoemulsification is not a feasible option due to its challenges with hard nuclei, hypermature cataracts, the need for costly equipment, expensive disposable materials, and foldable lenses. SICS has emerged as a more suitable alternative to phacoemulsification in such regions. SICS offers better unaided visual acuity, faster post-surgery recovery, and fewer surgery-related complications. During cataract surgery, all manipulations occur behind the iris, specifically in the posterior chamber of the eye. Maintaining pupil dilatation can improve the visibility of the posterior chamber, making surgery quicker and easier. Studies have shown that maintaining a pupil diameter of more than 6 mm during surgery can reduce the risk of posterior capsular rupture, a common intraoperative complication, by 50%. Cataract surgeries induces an inflammatory response in the eye, leading to the release of various mediators like prostaglandins, prostacyclin, thromboxane A2, leukotrienes, and others. These substances are associated with pain, redness of the conjunctiva, miosis, change in IOP, and posterior synechase. Preoperative application of topical NSAIDs can inhibit the release of prostaglandin and effectively maintain mydriasis during surgery, reducing complications such as posterior capsular rent. This study directly compares the impact of two topical NSAIDs, flurbiprofen 0.03% and nipafenag 0.1%. The study's specific goal is to measure horizontal and vertical pupillary diameters at the start and end of the surgery and to determine the total loss of mydriasis between the two groups. This study was designed as a prospective, randomized, double-blinded, longitudinal and comparative research project carried out at MDM Hospital, Jodhpur. The study was conducted over the course of 6 months from January 2023 to June 2023. A total of 70 patients who met the specified inclusion and exclusion criteria were enrolled as participants in the study. The inclusion criteria were as follows: 50 years of age or older, regardless of race or gender, diagnosed with senile cataract according to the lens opacity classification, scheduled for surgery by SICS and PCL implantation. The exclusion criteria included uveitis and glaucoma, alterations on the eye surface including dry eye, herpetic keratoconjunctivitis, diabetes mellitus, hypertension, history of ocular surgery, ongoing treatment, and or trauma in the eye scheduled for operation, allergy or hypersensitivity to preservatives, topical NSAIDs, or any other component of the study medication. Use of eye medications including prostaglandin analogs within 30 days prior to inclusion in the study, apart from artificial teardrops. Use of topical or systemic steroids within 30 days prior to inclusion in the study. Preoperative mydriasis less than 6 mm prior to the study. During the preoperative visit, patients and their relatives were thoroughly explained about the study and written informed consent for the study was taken. Pre-op, all patients underwent a thorough ophthalmic examination. Past medical history, surgical history were taken. BCVA using Snellen charts, slit lamp biomicroscopy, IOP, and dilated fundus examination were done. A general surgical consent was obtained from all patients. Patients were randomly assigned into two groups, Group A and B. Subjects in two groups were treated either with nipafenag eye drop 0.1% or flurbiprofen eye drop 0.03%. According to the randomization, with a dosage of 1 drop TDS 1 day before the surgery and 4 times every half an hour on the day of surgery. Mydriatic phenylephrine 5% or tropicamide 0.08% eye drop were given preoperatively to all subjects 4 times at a rate, 1 drop every half hour on the day of the surgery. Unpaired t-test was used to determine the differences of pupillary diameter between the two groups. All analyses were two-tailed with p-value less than 0.05 considered as significant. Analyses were performed using GraphPad and ASSET demo. Results were total 84 subjects were screened for this study, of which 70 patients were included. 35 were randomly selected for each group. No intra-op complication was encountered among these 70 cases. There were also no serious treatment-related adverse events or toxicity related to use of flurbiprofen and nipafenag. With respect to the maintenance of mydriasis during cataract surgery, the average pre-op vertical pupillary diameter was comparable for both groups. The pupillary size at the conclusion of surgery was significantly different in two groups. The total reduction in vertical pupillary diameter from the beginning to the end of surgery was significantly less in nipafenag group compared to the flurbiprofen group. There were no significant difference in the preoperative horizontal pupillary diameter of the two groups. The pupillary size at the conclusion of surgery was significantly different in two groups. The total reduction in horizontal pupillary diameter from the beginning to the end of surgery was significantly less in nipafenag group as seen in table number 3. Discussion is during cataract surgery, various manipulations like incision, iris manipulation, anterior chamber shallowing are important in role in causing miosis. Commercially available topical NSAIDs, if applied before the operation, are therapeutically useful. Nipafenag is only topical NSAID which is structured as a prodrug. That is why it is biologically more available and it results in more
greater effect. Intraocular drug concentrations are an important determinant of the anti-inflammatory efficacy of a drug. The near maximum concentration of amphenac, which is active form of napafenac, is maintained longer. That may explain the prolonged duration of action of napafenac relative to the other drugs in this class. Conclusion is the findings of the study suggest that napafenac is more effective in maintaining pupillary dilatation compared to flurbiprofen. This superiority is likely attributed to the prodrug formulation of napafenac, which enhances its absorption, bioavailability, and distribution within the eye. Further research is needed to validate the results of our study. Thank you.
Thank you, Dr. Nidhi. Please collect your certificate from Dr. Kamal. Next speaker, Dr. Pawan Kumar. Dr. Sumit, please come here.
Good morning, everyone. My topic for the paper presentation is an observational study of visual outcome in traumatic cataract cases at Tertiary Care Hospital of Ajmer. Ocular trauma is one of the leading causes of visual impairment and blindness. Ocular trauma often leads to traumatic cataract along with damage to other ocular structures. In spite of recent diagnostic and therapeutic advances, traumatic cataract remains an important cause of visual impairment and physical disability. Pediatric population is significantly affected, particularly in the developing countries. The aim of my study is to describe the demography, nature of injury, and visual outcome in patients with traumatic cataract. What are the causes for traumatic cataract? It can occur secondary to the blunt trauma or penetrating trauma. Infrared energy, ionizing radiation, and electric shock can also lead to traumatic cataract. Pathophysiology, direct rupture of the capsule, coupe and counter coupe. Equatorial expansion due to hydraulic forces transferring the energy of trauma to the opposite side of the eye. It can also lead to anterior and posterior segment abnormalities depending upon the force of trauma and depth of globe penetration. My study was a prospective hospital-based observational study. Inclusion criteria: patient who were diagnosed as a case of traumatic cataract and patient who gave consent and were willing for the surgery. Patient with an unsure history of trauma, extensive time of presentation, extensive damage with auto expulsion of ocular contents. Patient having injury due to electric shock and X-rays were excluded from the study. Patient who reported to the ophthalmology OPD of JLN Ajmer and were diagnosed as traumatic cataract were included. It was a non-randomized study with purposive sampling. Study procedure: approval from the ethics board was taken. Written and informed consent was also taken from all the participants. History and ophthalmological examination was done, including the best corrected visual acuity, non-contact tonometry, slit lamp examination, and fundoscopic examination. All the patients included in the study underwent cataract surgery for traumatic cataract. Coming to the observation and results, my study included a total of 72 patients. 32% of the patients were between the age of 14 to 33%, followed by 28% in the age group of 34 to 48%, and 6% were in the age of less than 5 years. Most of the patients were male, accounting for 68%, and females were only 31.94%. Most of the patients were from the urban areas, accounting for 62.7%, and rural area patients were 47.2%. Maximum, the right eye was affected, followed by the left eye, accounting for 41.67%. Mode of injury: blunt trauma was more there in the 55.5% of the patients, followed by penetrating, accounting for 44.4%. The cause for the traumatic cataract was organic foreign body, accounting for maximum of 29.13%, followed by metal foreign body, accounting for 22.2%. Clinical characteristics of patient with traumatic cataract: preoperative best corrected visual acuity was 6/12 or better in 3% of the patients and worse than 3/60 in 83% of the cases. Postoperative best corrected visual acuity was 6/12 or better in 70% of the patients and worse than 3/60 it was in 16% of the cases. Time from injury to surgery was less than 1 month in 78% of the cases and more than 1 month in 22% of the cases. Corneal opacity was the leading cause of visual impairment, accounting for 11%, followed by secondary glaucoma 7%, and least was because of the traumatic optic neuropathy, accounting for 1.5% of the cases. Coming to the conclusion, traumatic cataract occurs mostly in younger males. Surgical intervention is necessary to improve the visual outcome. Good visual outcome was obtained in nearly half of the patients, and traumatic cataract patients can have good visual outcome depending upon the timely presentation and proper management. Thank you.
Thank you, Dr. Pawan. Please collect your certificate from Dr. Sumit. Next speaker, Dr. Pooja Hathiwal.
Good morning, everyone. I will be presenting on visual recovery after macular hole surgery and related prognostic factors. Introduction. Macular hole is when a circular opening forms in macula. As the hole forms, things in your central vision will look blurry, wavy, or distorted. As the hole grows, a dark or blind spot appears in your central vision. A macular hole does not affect your peripheral vision. Incidence rate is 8 per 1 lakh per year. A full thickness macular hole causes a reduction in visual acuity, central visual field scotoma, and possibly metamorphopsias. Causes: vitreous traction, injury, blunt trauma, diabetic eye disease, high myopia, and macular puckering. Risk factors: macular holes are most common in people aged 60 or older and seems to be more common in women with ratio of 2:1. Age is the primary risk factor. History of a retinal tear or detachment, diabetes, retinal venous occlusions, inflammations in the eye like uveitis. Spontaneous closure is rare, thus macular hole needs to be treated surgically by pars plana vitrectomy with fluid gas exchange and epiretinal and internal limiting membrane peeling. In this study, we tried to determine the prognostic factors that are favorable for macular hole surgery outcomes, like the size and the stage of the macular hole, duration of symptoms, and preoperative visual acuity. However, recovery of the macular contour and external limiting membrane and the ellipsoid zone are known to affect the recovery of the vision after surgery. Aim and objective: to determine the improvement in best corrected visual acuity after surgery, a successful 23 gauge vitrectomy, to evaluate the effects of related prognostic factors like the size and stage of macular hole, duration of symptoms, and preoperative visual acuity. Inclusion criteria: all patients of macular hole with written and informed consent, axial length less than 26.5 mm. Exclusion criteria: axial length more than 26.5 mm if patient had a previous vitrectomy surgery or developed a secondary macular hole. Material and methods: study design, a hospital-based interventional study. Sample size was 24 cases. All patients underwent a thorough ophthalmic evaluation prior to the surgery, including assessment of the best corrected visual acuity and a fundus examination. Patients with a full thickness macular hole were advised to undergo surgery. Surgery was performed using a standard 3-port 23 gauge pars plana vitrectomy. When a cataract was present, a combined phaco-vitrectomy was performed to remove tangential traction. Epiretinal membranectomy was performed. When a premacular membrane was present, there was no visual premacular membrane. The internal limiting membrane was peeled with brilliant blue dye staining. After removing tangential traction around the macular hole, air fluid exchange was performed, followed by 14% C3Fa tamponade. Patients were instructed to remain in a prone position for about 4 weeks after the surgery. Patients' age, sex, and involved eye were noted, and the BCA was measured before surgery and at day 1 and at 1, 3, 6, 9, and 12 months after the operation. There are some indices like macular hole index, which is macular hole height upon maximum basal diameter. Diameter hole index is equal to hole diameter upon maximum basal diameter. Tractional hole index is equal to macular hole height upon minimum inner hole diameter. Result: 24 eyes of 24 patients were included in the study. Visual acuity decreased to a mean of 3.077 1 day after the operation due to gas filling. All patients, 24, completed all routine follow-up visits. The mean BCVA values at 1, 3, 6, 9, and 12 months were 0.797, 0.592, 0.495, 0.496, and 0.427 respectively. When these BCVA values were compared with the final BCVA, preoperative vision and 1 day post-operative vision were found to be significantly different. Differences in BCVA were still significant at 1 and 3 months after the operation. At 1 month, p-value was 0.034, and at 3 months, 0.040. BCVA did not show improvements beyond 6 months after the surgery. This is the graphical representation of the BCVA. at 1, 3, 6, 9 month, 12 month, preoperative and immediate, and it shows the peaked BCVA between 15 to 20 days. There are some demographic characteristics and preoperative findings also which affects the BCVA. Discussion. In this study, we investigated the time to visual recovery after macular hole surgery and the related prognostic factors. Previously, the closure rate of macular surgery was 58%, but advancement in surgical techniques and devices had led to improvement in the closure rate to 89 to 100%. In the study, we were able to achieve closure in 23 patients of 24 cases using a standard 23 gauge vitrectomy system and found that vision was stabilized by 6 months after the operation. Landa et al. Asserted that the recovery of the ELM and the ellipsoid zone recovery also affects the visual recovery after macular hole surgery. We compared multiple factors of the ELM and ellipsoid zone recovered groups with those of the unrecovered groups. Recovery of the ELM is essential for the ellipsoid zone recovery. We also analyzed OCT data and found that ellipsoid zone recovery was seen only after the ELM was restored. Shinoda et al. Reported that the visual recovery at 3 months after the macular hole surgery in 25 gauge vitrectomy and at 9 months after surgery in 20 gauge vitrectomy group. Less trauma to ocular surface, a shorter operation time, and a reduced amount of irrigation fluid were considered to be region of shorter time to visual recovery in the 25 gauge vitrectomy group. In this study, we performed 23 gauge vitrectomy and vision was stabilized by 6 months after the operation. Conclusion. In conclusion, visual acuity stabilized after 6 months in macular patients who underwent 23 gauge vitrectomy. Final visual acuity was poor in patients with larger basal hole diameter. Greater choroidal thickness was a prognostic factor for final BCVA. Greater visual improvement was seen in patients with a poor initial BCVA and thick subfoveal choroid. The ellipsoid zone showed poor recovery in patients with a larger base hole diameter and a greater axial length. Based on these results, we were able to identify the factors that influences the visual recovery after macular hole surgery. This information will allow for the better stratification of the patient who are more likely to be benefited from the surgical macular hole repair. Thank you.
Thank you, doctor. Very well delivered talk. Please collect your certificate from Dr. Rajesh Malpani. And next speaker, be prepared. Dr. Pooja Kisarwa.
Good morning everyone. I am here to present my paper on topic ocular morbidity in road traffic accident at Tertiary Care Hospital. Introduction. Any trauma to eye or its surrounding tissues is most common cause of attendance in an eye hospital emergency. The extent of trauma may range from simple superficial injuries to devastating penetrating injuries of eyelid, lacrimal system and globe. Surgical management of such injuries is primarily for the restoration of normal ocular anatomy. The ultimate target is to prevent secondary complication and maximize the patient visual prognosis. Eye injuries are major and under-recognized cause of disabling ocular morbidity. The public health importance of ocular trauma is undeniable. Injuries generate a significant burden on society in terms of medical care, human suffering, long-term disability, productivity loss, and rehabilitation services and socio-economic cost. Aim and objective. Aim of my study is to study the incidence of ocular injury in road traffic accident. Objectives are to determine the pattern of clinical presentation of ocular injuries in road traffic accident and final visual prognosis after effective management in ocular injuries. Material and methods. All the patients with the history of road traffic accident presenting to the trauma center in SMS Hospital from June 2023 to August 2023. Inclusion criteria are all the patient willing to give informed consent and patient with ocular injury due to road traffic accident and patient over the age of 18 years. Exclusion criteria. Patient with ocular injuries other than road traffic accident. Methodology. Detailed history were taken from the patient and attendant. A thorough examination using torchlights was done. Visual acuity was recorded. This is followed by examination under slit lamp for the more detailed examination. Gonioscopy was performed. IOP is recorded and direct and indirect ophthalmoscopy is performed wherever required. Plain X-ray in AP and lateral view taken. B-scan ultrasonography was performed in the cases where media opacities are present. CT and MRI are taken to rule out intraocular foreign body. Depending on presentation of the patient, a detailed examination by ENT surgeon, general surgeon, and plastic surgeon and general physician taken. Patients were managed mainly at casualty and OPD. Patients were followed up at every week after they are discharged from hospital. Discussion. This study includes total number of 1050 road traffic patients, out of which 95 patients have the ocular injuries. The incidence of ocular injury were 90.4 out of 1000 RTM. Majority of ocular injury occurred in the age group of 30 to 40 years. Least number of cases of RTA were seen in the patient above the age of 50 years. Out of 95 patients, 67 were males and 28 were females. Out of 95 patients, the ocular injuries, 53 patients were on two-wheeler motors and 20 patients on four-wheelers. Total number of 11 patients have orbital fractures. Ecchymosis was most common clinical features. Out of total number of 95 patients, 47 patients have ecchymosis. 46 patients have ecchymosis which were associated with other clinical findings. Subconch hemorrhage was most common clinical finding in my study. 51 patient cases have subconch hemorrhage and 16 patients have cornea involvement. 2 patients have scleral laceration. None of them have full thickness scleral tear. Only 3 patients have hyphema. And 9 patients have lenticular involvement, out of which 6 have traumatic cataract, 2 patients have subluxation, and 1 patient have dislocation of the lens. In 20.10% cases, glass has a major ocular injury followed by road traffic accident. Out of 95 patients, 7 patients have posterior segment involvement, 2 patients have vitreous hemorrhage, 2 patients had traumatic optic neuropathy, and 2 patients have Berlin's edema, 1% has preretinal hemorrhage. The hemorrhage has resolved after 6 weeks with no sequelae. Traumatic optic neuropathy, 2 patients have traumatic optic neuropathy. Both of the patients presented with no light perception of light. Even after 6 weeks, they didn't get any vision. Conclusion. Incidence of ocular injury in this study is 90.5. The majority of ocular injury occurred in the age group of 30 to 40 years. Least number of cases of RTA were seen in the patient over the age of 50. Male predominance was found with the ratio of 2.4:1. At the end of 6 weeks, 61 patients have the good vision in the range of 6/6 to 6/12. 26 patients have vision range with 6/18 to 6/60, and 6 patients have vision with less than 6/60. Only 2 patients which previously presented with no perception of light due to tone showed no improvement in visual outcome. Thank you.
Thank you, doctor. Any questions from audience? Please collect your certificate from Dr. Rajesh Malpani. Next speaker is Dr. Purvi Gandhi.
Good morning, everyone. Myself, Dr. Purvi Gandhi. I am presenting my study on comprehensive study on refractive error in pediatric population at a tertiary level eye hospital. Children see the world without filters and biases that often come with age and experience. They have a natural, uncorrupted way of perceiving the world. For that, they must see. Visual impairment affects all aspects of child's life, like social and psychosocial factors. So, for that, an early correction would make their life easier. We did a retrospective study on children where we selected children aged 5 to 18 years and the age was taken at first visit. The study was conducted between April 21st and March 23. We collected the data of 4,832 children in a retrospective manner, and their age, gender, symptoms, and visual acuity was noted. Other factors like family history, their school performance, and their best corrected visual acuity were noted. Cycloplegic refraction, if needed, was done, and their ocular anomalies associated were also noted. The prevalence of refractive errors in 4,832 children were found to be 43.4%, out of which myopia dominated with 60.73%, followed by astigmatism, followed by hypermetropia. The graph shows myopia had the highest incidence and myopic astigmatism dominated over hypermetropic astigmatism. Myopia could be mild, moderate, or high. Mild is 0 to 2 diopters, moderate is 2 to 6 diopters, 3 to 6 diopters, and high is more than 6 diopters. In this, mild myopia dominated the group. Myopic subgroup analysis showed children between 14 to 18 years had the highest prevalence of myopia. The risk factors, certain risk factors were identified for myopia. Age was the biggest risk factor, the strongest risk factor. The myopia progressed with age. That is why 14 to 18 group children had the highest prevalence of myopia. Other factors were race, gender. The new emerging risk factor is the environmental factors, that is lack of outdoor activities. The digitally occupied kids using their phone all the time increases the risk of myopia. Now the hypermetropia. Hypermetropia could be classified as mild, moderate to high, but mild hypermetropia is 0 to 3 diopters. The 0 to 3, moderate is 3 to 6, and high is more than 6. Here also mild hypermetropia dominated. Hypermetropic subgroup analysis showed no much variation between all three subgroups. Astigmatism. Astigmatism could be myopic, hypermetropic, or mixed. Here, simple myopic astigmatism dominated the group, and there were minimum children of mixed astigmatism. We compared our study with an earlier existing study in general population. Our study was in a hospital. We compared the study, the prevalence of refractive error among school-going children in a multi-state study, where we found out that refractive error were of course less than our study, but the prevalence of myopia, astigmatism, and hypermetropia, the percentage were comparatively same. Apart from refractive error, the patients approached healthcare for conjunctivitis, ocular trauma, cataract, eyelid swellings like lesions, stye, hordeolums, allergic diseases, some retinal conditions. Additional findings that we could note from our study were that many hypermetropic and many high myopics presented to the OPD for the first time to our hospital. Also, amblyopic patching, good compliance with it, and foot follow-ups improved vision. Also, vision therapy in squint decreased the need for squint surgeries. The results which we can draw from this study: firstly, myopia dominated the group, followed by astigmatism, followed by hypermetropia. Secondly, the risk factors for myopia. Firstly, age. Second, familial. Genetics played an important role in myopia. The family history of myopia increased the prevalence of myopia. Thirdly, environmental. Environment showed that patient with less outdoor activities and more screen time showed an increased prevalence of myopia. Thirdly, the prevalence of myopia was more in 14 to 18 years, whereas prevalence of hypermetropia does not change much with age. Also, simple myopic astigmatism was maximum and mixed astigmatism was minimum. The conclusions we can draw from a study is targeted public health initiatives, eye camps, eye checkups, regular would prevent long-term visual impairment. Secondly, we studied patterns, prevalence, and risk factors for various refractive errors, mainly myopia. Thirdly, the findings highlight the importance of early detection and management of refractive errors. Thank you.
Thank you, Dr. Purvi. Please collect your certificate from Dr. Kamal. Next speaker, Dr. Raju Beniwal.
Good morning everyone. I am here to present my study on a comparative intervention study of silicone oil on peripapillary capillary perfusion in patients with RRD. Introduction. RRD is the separation of sensory retina from RP, that is vision threatening disorder. Radial peripapillary capillaries are the deepest layer of capillaries that run parallel to peripapillary RNFL and responsible for feeding RNFL as it is dispersed throughout the optic nerve head. RRD present a suitable model to assess the influence of silicone oil on RPC since the optic nerve head presentation may be devoid of intrinsic vascular abnormalities. Its high viscosity and surface tension characteristic make it superior to gas tamponade. Our study evaluated RPC vessel density as global superior and inferior quadrant at optic nerve head. Aim of my study is to compare changes in RPC perfusion after silicone oil tamponade and silicone oil removal in RRD patients using OCTA. Methodology is it is hospital-based single-center prospective intervention study. All patients underwent a full ophthalmological examination, including BCVA, slit lamp examination, and OCT. A total of 26 patients were included, repaired with 23 gauge PPV and silicone oil tamponade. We studied patients before and after silicone oil removal with follow-up at 1 week, 1 month, and 3 months. Selection criteria. Inclusion criteria is age group 25 to 60 years, IUP between 10 to 21 mmHg, patients with RRD surgery with silicone oil insertion and normal contralateral eye. Exclusions are patients with recurrent RRD requiring secondary repair, eyes with other choroidal and retinal disorders other than RRD, eyes with poor octa images, eyes that had silicone oil removal combined with ERM peeling, which might cause iatrogenic RNFL changes and radial papillary capillary changes. These are results of my study. First image showing pre-SOR RPC vessel density, and second image showing post-SOR RPC vessel density, which is showing significant increase. These are patient demographic and clinical characteristics which are not significantly associated with optic nerve head vessel density. Vessel density changes before and after SOR in affected and contralateral eye, showing global RPCVD with p-value 0.09%, which is very significant in superior and global quadrants. Discussion. This study shows that the vessel density of RPC vessel density increases statistically significant after silicone oil removal. These results raise concerns regarding how silicone oil could affect the microvascular blood flow at the optic nerve head. To minimize systematic errors, we use healthy PRI as control. We collected our major outcome measures at least 3 months after the original vitrectomy and silicone oil removal surgery. This period of time assured that intraocular pressure changes and acute post-operative inflammation had subsided, and minimizing their possible influence on RPCVD readings. We also took into account variables such as IOP variation, diurnal variation, and BP that can have an impact on octa changes. We attempted to reduce the influence of these possible confounders by using colleague eye as control and taking data many months after silicone oil removal. After silicone oil removal, the RPC superior hemifield showed a more severe rise in vessel density than the inferior hemifield. This shows that the superior microvascular may be more affected by silicone oil. These results are concordant with Wong et al. Study. Conclusion. This study is the first to examine how silicone oil affects peripapillary blood flow. After silicone oil removal, it shows a slight but considerable rise in RPC vessel density, raising the possibility that this may have an impact on microvascular blood flow surrounding the optic nerve head. The clinical importance of these observations must be clarified, and the implications of extended silicone oil tamponade on RPC vessel density must be investigated. This study also added new insight to a complex biological mechanism of silicone oil related optic neuropathy. These are references. Thank you.
Thank you, Dr. Raju Beniwal. Please collect your certificate. Next speaker, Dr. Pooja Keshwani.
Good morning, everyone. I am going to present a study done to compare the effectiveness of the vector thermal pulsation, that is the LipiFlow, along with the hot fermentation and the massage versus the hot fermentation and massage alone in treating the dry eye patients. The aim of our study is the same as the title. The objective is to evaluate the subjective and the objective improvement in the signs and the symptoms. The introduction. The obstructive meibomian gland dysfunction is the most common cause of the evaporative dry eye. The definition of the meibomian gland dysfunction based on the report of the International Workshop on the MGD, which was finalized in the 2010, is a chronic diffuse abnormality of the meibomian gland, commonly characterized by the terminal duct obstruction and or qualitative or quantitative changes in the glandular secretion. The LipiFlow is an FDA-approved treatment, consists of a sterile single-use disposable activator and a console that regulates the heat and pressure applied to the eyelids to liquefy and evacuate the meibum from the glands. The working principle of the LipiFlow, it's a 12-minute duration procedure. It starts with a 4 minute of regulated heat at 42.5 degrees centigrade, maintains this heat throughout the entire 12-minute procedure. Once at therapeutic temperature, the pressure sensors activate to apply the 5.2 psi pressure to the meibomian glands. The material and the method. The study design type is the prospective non-randomized. This study was conducted in Dr. Viren Laser Phacosurgery Center, Jaipur, between 2 Jan 2023 to 19 Jan 2024, with a sample size of 44 subjects in each group out of 2 groups. The sample size was calculated at 80% of the study power and the alpha error of 0.05, assuming the standard deviation of 23.1 in the OSD score at the baseline in the hot fermentation group. The study parameters include the following. The inclusion criteria is the age more than 18 years, willing to comply with the study procedure and the follow-up. The evidence of the bilateral meibomian gland dysfunction on the clinical evaluation. The ocular surface disease index questionnaire score and the mean lipid layer thickness less than 60 nanometer. The exclusion criteria is less than 18 years. The active ocular infection or the inflammation, the vernal or the giant papillary conjunctivitis, the ocular surface abnormality, the dysfunctions of the structural abnormality of the eyelids, contact lens wearer, continuous eye drop use other than the artificial tears that do not contain the lipids, recent within the last 3-month ocular surgery or the trauma, the punctal plaques or the punctal occlusion within the past 3 months, the systemic disease condition associated with the dry eye, the use of the systemic or the topical medication known to cause the dryness. The study population was divided into the 2 groups: those who received the LipiFlow treatment and those who did receive only the warm compresses followed by the massage. Both the intervention and the control group were given the following medication: the loteprednol etabonate 0.5%, and the eye ointment azithromycin 1%, eye drop trehalose 3% plus sodium hyaluronate 0.1% combination, tablet azithromycin, and the tablet cholecalciferol. The OSD score, the patient rate their responses on a 0 to 4 scale on this 12 item questionnaires. The Shermer's one test, the reading of less than 10 mm was taken as a baseline parameter. The lipid layer thickness of less than 60 mm is taken as a baseline parameter. The fluorescent tear breakup time of less than 10 seconds was taken as one of the baseline parameter. The patients were divided into the 2 groups equally based on the meibography, and these are the 3 scales according to which we divide the patients into the 2 groups, that is the PERLD 5 grade scale, Hallerian grading scale, and the Leo grading scale, and the more than or equal to 1 degree or grade according to each of 3 scales was taken in our study. The statistical analysis, SPSS statistic version 20 was used to analyze both the qualitative and the quantitative variables. Data were summarized using the mean, standard deviation, and the frequency. The baseline data of our study was the gender, male is to female ratio was the results. The significantly greater improvement was observed in the tear breakup time, and the significantly greater decrease in the ocular surface disease index was observed in the LipiFlow group. The conclusion: the LipiFlow along with the hot fermentation and massage is more effective than the hot fermentation and massage only in the patients of the evaporative dry eye. Thank you.
Thank you, doctor. Doctor, you mentioned the duration of the study from 23 to 24. So it's an ongoing study.
Yes.
Okay, thank you. Please collect your certificate from Dr. Rajesh Malpani. And the next speaker is Dr. Rakesh Kumawat.
Hello, good morning everyone. My topic is evaluation of lacrimal drainage system by various diagnosis method in patient with epiphora at tertiary care center in Rajasthan. Introduction. Epiphora is the common presentation to the general ophthalmologist. Causes of watering eye are either secretory problem called a hyperlacrimation or problem with the excretory side of lacrimal system. Early evaluate and analyze epiphora is very important because it can create many issues like eye pain, discharge, itchiness, red eye, cloudy or unclear vision, sinus headache, infection in lacrimal drainage system. Endophthalmitis may cause if intraocular surgery done in the epiphora implies overflow of tear due to impairment lacrimal drainage system or functional pump failure. This is the cause of watering, different cause of watering eye disease, overproduction, reflex tearing or under drainage. This is the applied anatomy of the lacrimal drainage system, the punctum, canalicular, lacrimal sac, NLD, and this is the causes of the punctal obstruction like conjunctival ectasia, acquired stenosis or scarring. Canalicular obstruction caused by fibrosis or chronic lacrimal sac obstruction caused by granuloma, tumor, primary, secondary lymphoma, and the most common nasolacrimal duct obstruction caused by congenital traumatic nasal pathology, inflammation, polyp, tumor, and post-eradication fibrosis. Method and methods. The study will be conducted after taking an informed consent from patient of their relative in the Department of Ophthalmology, JL Medical Ajmer. Sample size: all the patients who have complained of epiphora in outpatient department of tertiary care center Ajmer. Study type: cross-section study. Study duration 6 months, and sample method: random sampling. Including criteria: patient with watering eye age above more than 4 with known pattern lacrimal drainage system, including failed DCR surgery, either external or endoscopic DCR. Exclusion criteria: patient were not willing to attend perform these tests, patient with age less than 4 years, and acute acrocystitis, local sepsis near punctal and lacrimal sac region, and sensitive to the iodine test. Patient who are pregnant are excluded in this criteria. Total 35% with complaint of epiphora were evaluated by serial diagnostic method as required. Detailed history: patient acute onset or gradual pain, seasonal direction variation, and sinus surgery, medication and chemotherapy, foreign body etc. Still time examined by lead punctum and conjunctival anomaly. Test performed as required: Aeroplas, fluorescent dye difference test, Jones dye test, sac syringing, probing, endoscopic nasal examination, and imaging. We exclusively conduct dacrocystography in this study. In the different test, we mentioned the Roplas test procedure. You can see here. This is the dacrocysty picture in JLN hospital. The visualize passage. This is the best way to visualize the passage and know the exact side, nature, and extent of the block. In this passage, inject radiopaque material like lipodipol in the sac with cannula. Take X-ray after 5 minutes and 30 minutes. Results: in this less than 20 year age, 24% with epiphora, 20 to 40%, 12%, more than 40 year is 66%. In the sex distribution, female are more complain of epiphora than male. Causes of epiphora: lacrimal pump for 8%, pseudoepiphora 12, the nasal cause 6, punctal cause 12, canalicular cause 10, and most common cause is nasal lacrimal obstruction 52%. Result: the activity: describe the pathophysiology of epiphora, comprehensive review the cause of epiphora, discuss the best related examination required the apply the patient. Female have higher chance than the of epiphora than male because it is smaller nasolacrimal duct, Decrocystography is the good method to evaluate the site of blockage, anatomical irregularity, functional capability, and the pathological abnormality of lacrimal drainage system. A thorough study and examination are required to provide the appropriate treatment tailored to the underlying cause. Thank you.
Thank you, Dr. Kamal. Please collect your certificate from Dr. Kamal Sera. Next speaker, Dr. Ravina Tayal.
Good morning, everyone. Today, I am presenting my paper on bacteriological spectrum and antibiotic susceptibility patterns in chronic dacrocystitis patients. Dacrocystitis is an infection of the nasolacrimal sac of an eye, frequently caused by nasolacrimal duct obstruction. It is of two types, congenital and acquired. Congenital dacrocystitis is typically due to obstruction of the valve of Hassner, and acquired causes include involutional changes like aging, systemic disorders like sarcoidosis, trauma, surgeries, neoplasm, and certain medications involving timolol and pilocarpine. Symptoms: pain, epiphora, discharge, and signs are redness and swelling over medial canthus. Pathogenesis include nasolacrimal duct obstruction leading to insufficient lacrimal drainage, which leads to colonization of organisms, resulting in infection and inflammation and fibrosis, which leads to erythema and edema over medial canthus and discharge. It is a cross-sectional type of study which was done between September 2022 to August 2023, and it was done in the Department of Ophthalmology of Sardar Patel Medical College, Bikaner, and 40 cases of chronic dacrocystitis were taken in the study. Inclusion criteria: clinically diagnosed cases of chronic dacrocystitis aged between 18 to 60 years and patients who give informed consent. Exclusion criteria include patients with acute dacrocystitis, lacrimal abscess, mucocele, and malignancy, the patient who had received either topical or systemic antibiotics in the past 1 week. Procedure of the sampling: after cleaning with normal saline swab, pressure was applied on medial epicanthal fold. The regurgitant was collected by 2 sterile swabs. Inoculation of specimen was done following standard procedures. The sample from swabs were inoculated directly onto the different media like blood agar, chocolate agar, and McConkey agar. The inoculated media were all incubated aerobically at 37 degrees centigrade for 24 hours and examined daily, and declared as culture negative after 5 days if no organism had grown. Significant microbial growth was considered when positive culture was obtained for the same organism in more than one type of solid media, or there was heavy growth in one solid media at the site of inoculation. Positive growth culture was followed by bacterial identification according to colony morphology and gram staining. Antimicrobial susceptibility tests were applied to all bacterial isolates according to the standard Kirby-Bohr disc diffusion method. The following antibiotic discs were used: gentamicin, amikacin, getafloxacin, ciprofloxacin, levofloxacin, ceftazidime, cephalexin, cefotaxime, and chloramphenicol. The result of the sensitivity test were recorded as sensitive or resistant. Now results. The average age of the patients were 50 years. And among the cases, male to female ratio was 1:2.07, and bacterial isolates were obtained from 62.5% of patients, and 37.5% patients were sterile. Out of 25 bacteriologically positive patients, 17 were gram positive and 8 were gram negative. Most common organism that was isolated was Cohn's coagulase negative staphylococci, followed by Staphylococcus aureus. The gram-positive bacteria were most sensitive to vancomycin, getafloxacin, and ufloxacin, and gram-negative was most sensitive to amikacin and gentamicin. This is the distribution of bacterial pathogens isolated from patients with chronic dacrocystitis, in which maximum was Cohn's, followed by Staphylococcus aureus. Then these are the organisms which are founded: Streptococcus pneumoniae, MRSA, Pseudomonas, Klebsiella, Enterobacter, Corynebacterium, and H. influenzae. These are the antibiotic sensitivity patterns of gram-positive bacteria sensitive to vancomycin, getafloxacin, ufloxacin, and these ones. And this is the antibiotic sensitivity pattern of gram-negative bacteria. Now, discussion. The most common inflammation of the lacrimal apparatus is dacrocystitis. This mucous membrane lined tract is continuous with two surfaces, conjunctival and nasal mucosa, that are normally colonized with bacteria which have direct role in the pathogenesis of chronic dacrocystitis. Majorly, chronic dacrocystitis is caused by gram-positive bacteria, and in that too by cones. This is in concordance with previous studies. This is more common in old age patients. Females are at greater risk. Many previous studies have noted a similar gender predilection. A narrower bony nasolacrimal canal and hormonal factors in females have been proposed to be the causes for this gender preponderance. Majority of cases, 72.5%, belong to lower socioeconomic class 4 and 5 according to Kuppuswamy scale. Similar observation was noted in previous studies. Conclusion. The study showed that bacterial isolates from dacrocystitis patients were diverse in terms of their distribution, prevalence, and pattern of antimicrobial drug resistance and sensitivity. Microbiological analysis and antimicrobial susceptibility pattern is mandatory for the selection of a specific antimicrobial therapy and to control of further resistance development of bacterial strains. The limitations of there were some limitations to the study. It was a single center study. Relatively small sample size was there. The specimens was not cultured in anaerobic media, and maybe it is responsible for some of the culture negative cases. And the other is the sample taking technique. There was a possibility of contamination and inoculation of conjunctival flora along with lacrimal secretions. These are the references, and thank you.
Thank you, doctor. Please collect your certificate from Dr. Rajesh Malpani. Thank you, audience and participants, for your patience and participation. Thank you.
Given 4 minutes, and you have to present your talk as a faculty. So you yourself has to play, a role play you have to do like a teacher, and consider all of us as your students. So don't present like you are presenting a free paper. So you have to teach the hall, okay, like your teachers do. Okay, so the way of presentation, then the content of presentation, your time management, and if at all the judges have any question for you, all will be considered, and the total marks of 40 will be means out of the 40 you will be allocated the marks. Okay, so remember the time limit, and because a few of your colleagues, they are having a simultaneous paper presentation in other hall, so we'd like to have a little change in the sequence. So I'd call Dr. Sapna for her presentation, and she'll be speaking on the topic of Dr. Sapna is demystifying amblyopia. Okay, so we are just waiting for our third judge. As soon as she is here, you can start your presentation. Okay, so you can take your position.
Can we go there? अच्छा, यहाँ से. Okay. They are presenting on the ना तभी. ठीक है. हाँ, इनको question पूछना है. As you HOD at the Jailand Medical College, Ajmer, she needs no introduction. Our another esteemed judge is Dr. Ankur Sinha. He is a well-known glaucoma and strabismus specialist, ex-RP Center alumnus. And we have Dr. Preeti Goyal. She is also a executive member of JOS and a glaucoma specialist. So first, I'll call Dr. Sapna. She is a resident JR2 from SMS Medical College and mentor under the mentorship of Dr. Rajesh Goyal. She'll be presenting her topic on demystifying amblyopia. So the timer, we can start now.
Good morning, everyone. I'm going to give a brief presentation on amblyopia. Since amblyopia is not only one of the common causes of childhood onset unilateral decreased visual acuity, it is also one of the most common causes of unilateral decreased visual acuity in adults less than 60 years of age. It is very important to understand amblyopia and its treatment. What is amblyopia? It is a developmental disorder of the neurovisual system. Non-similar images from the two eyes cannot be fused in the visual cortex, and therefore the blood image is simply discarded. Also, the neurons of the good eye in the visual cortex suppress the neurons of the bad image of the other eye. This elimination of the bad image depends upon the severity of defect and thus the severity of amblyopia. When we do suspect amblyopia in a child, if there is decreased visual acuity in children, children can present decreased visual acuity if they will try to suppress the blood image by either closing the eye or rubbing the eye. There may be decreased contrast sensitivity, or there may be poor hand-eye coordination and decreased depth perception. Since both these actions require depth stereopsis, if the child has poor hand-eye coordination or poor depth perception, he or she may be suffering from amblyopia. The causes of amblyopia. The most common cause of amblyopia is strabismic amblyopia. In this amblyopia, since a child favors one eye for fixation, the eye will subsequently develop amblyopia. It is more common in unilateral strabismus than alternating fixation patterns, because alternating fixation pattern, the child will not favor either eye. Strabismic amblyopia is more common in esotropes than it is in exotropes. The other cause of amblyopia is refractive amblyopia. There may be three causes in refractive amblyopia. First is anisometropic amblyopia. If the refractive error is dissimilar in two eyes, generally in myopia it is 3 diopter, and in hypermetropia it is 1.5 diopter. If there is isometropic, then if the refractive error is large, approximately equal, uncorrected in two eyes, then it may also develop. Then meridional amblyopia, if there is uncorrected bilateral astigmatism, then the child may also develop amblyopia. Third is visual deprivation amblyopia. This is also called as amblyopia ex anopsia, because there is no visual sensation in this amblyopia. Any eye abnormality that obstructs the visual axis or otherwise interferes with central vision. If there is any abnormality in corneal lens or vitreous, then the child may also develop amblyopia. The causes of visual deprivation amblyopia may range from congenital cataract to blepharospasm, surgical lid closure, unilateral complete ptosis, and corneal opacities. The diagnosis of amblyopia. If there is difference of at least 2 lines in Snellen's chart after best correction, the fundus is normal. Crowding phenomena. The child will read normally a isolated letter, but if there is lines, then the child may face crowding phenomena. Treatment aims: first, treat the cause of visual deprivation, then correct any significant refractive error. Force the use of amblyopic eye by limiting the use of the better eye. In refractive correction, full correction should be given in astigmatism, myopia, hypermetropia, and anisometropia. And hypermetropia, if there is no esotropia, then it should be undercorrected. The better eye can be limited by using the occlusion therapy, pharmacological penalization, and Bangerter filters. In patching, there are 2 methods, either adhesive patches or there are also spectacle-mounted occluders available. In patching, it has been found that 2 hours is as effective as 6 hours of daily patching in moderate amblyopia, and in severe amblyopia, 6 hours is as effective as full-day amblyopia. Prescribing less amounts of patching may promote better compliance with treatment. Pharmacological
Your time is up,
Time is up.
Dr. Sapna.
Okay.
So,
Yes, ma'am. Ma'am, the hypermetropic eye. Because the hypermetropia itself has a complication of esotropia, then because of that esotropia. Okay.
What about the accommodation?
Yes, ma'am. The accommodation will be affected.
And you talked about the types of amblyopia.
Yes, sir.
What is the most common anomaly of the children? क्योंकि ये समझ नहीं आया कि भाई कैसे
Hypermetropia. So in children,
ऐसा जरूरी नहीं है कि hypermetropia is the most common form of refractive error. But if you talk about the causes of amblyopia, like a refractive amblyopia or a strabismic amblyopia or a visual deprivation amblyopia, which type of amblyopia is the most common?
So, strabismic amblyopia. There is
So you mean to say
controversy
strabismus?
about.
No, there is no controversy.
Okay,
about
sir.
it. The most common form of amblyopia is
Strabismic amblyopia.
refractive
Okay,
amblyopia,
okay, sir.
because refractive errors are much more common. So as ma'am said that high hypermetropia does not allow, despite accommodation, it does not allow clarity of the image, and very high hypermetropia, like say if it is +10, even if child tries and accommodate, would not be able to accommodate that much. Then it will not cause squint. Squint will be there only in patients who have refractive error from +2 to +6, because then that is beyond their capability of accommodation to see clearly, right?
Okay, sir. Yes, ma'am.
All right, thank you, Dr. Sapna. So next we have Dr. Abhas, and he is a junior resident from Mahatma Gandhi Medical College, and under the mentorship of Dr. Jaya, he'll be presenting his talk. So I'll also request all of you to present your talk as if you are taking a class of your students, okay? So stick to that kind of a presentation.
Good morning, everyone. I'm Dr. Abhas Kumar, resident from Mahatma Gandhi Medical College, Jaipur. And my topic today is Back to Basics, Get Your Diplopia Charting Right, because sound basics are the foundation of a good clinical examination. So our objectives for the session today would be to know the correct method of plotting a diplopia chart and how to interpret a diplopia chart. So diplopia charting is a record of separation of diplopic images in all the 9 positions of gaze, and there are certain prerequisites before we do a diplopia charting, which are that the patient should be cooperative and it should be able to assess the double vision. Before going into diplopia charting, we should understand the yoke muscle. We should understand the yoke muscle action in all the six positions of cardinal gaze, because the separation which we will see in the image in the diplopia charting will be due to underaction of one or more of these muscles. Another important concept to learn here is about crossed and uncrossed diplopia. In the first image, we can see that the right eye is in esotropia and the light coming from the object is falling on the nasal part of retina. And so the image is the false image which is being perceived by the brain is falling on the temporal side and is forming on the temporal side. And so we can see that there is no crossing of the object and the false image. So it is an uncrossed diplopia. While in the second image, we can see that the right eye is in exotropia. So the light falling from the object is falling on the temporal side, and the image is forming on the nasal side. Since there is crossing of the object and the false image, it is a cross diplopia. So for the method, we'll ask a patient to be seated in a dark room, and Armstrong glasses are used where the red color is used in front of the right eye and green is used in front of the left eye. After this, a vertical streak of light is projected on the wall from a distance of 1 meter or half meter to the patient, and patient is asked whether he can appreciate a single fused image or two separate images. Colored pencils are given to the patient to indicate the separation and tilt in the image. It is done in all 9 positions of gaze, and a diplopia chart is plotted, which looks something like this. So for assessment of diplopia chart, we need to ask these following questions to ourselves. Which eye is affected? In this, the red line is for the right eye and the green line is for the left eye, and whichever line is deviated from the midline is the eye which is affected. In our case, it is the left eye. Is it a crossed or uncrossed diplopia? Generally, the red line in an uncrossed diplopia, the red line is on the right side and the green line is on the left side. And in our example, we can see that the green line is on the left side, is on the right side, and red is on the left. So it is a cross diplopia, and so the eye is in exotropia. Is there any vertical separation present? We can see that both our lines are in the same vertical height, so there is no vertical separation present, which means that the muscle affected are the horizontal muscles. And finally, which position shows the maximum separation? We can see that the maximum separation which we are seeing is in the dextroversion position. That means the muscle affected is either the right lateral rectus muscle or the left medial rectus muscle. And since our left eye is affected, the muscle affected is left medial rectus muscle. We'll go through another example here. Here we will go to the same set of questions again. So the eye affected here is the right eye, since it is deviated from the midline, And it is an uncrossed diplopia since red color line is on the right side and the green color line is on the left side. And is there any vertical separation present? Yes, we can see that there's a vertical separation present, more so in the down case, which shows that the depressor muscles are involved in this. And which position shows the maximum separation? The maximum separation we can see is in the levodepression position. That means the muscle affected is either the right superior oblique or the left inferior rectus muscle. And since the right eye is affected, our muscle affected is the right superior oblique muscle. That's all for the session. Thank you.
Thank you, Dr. Abbas. That was right on time. We also have been joined by our fourth esteemed judge, Dr. Arun Singhvi. He is the founder and director of ASG Group of Eye Hospitals. So if we have any questions for Professor Abbas.
I'm just asking. You are telling it we should have read red and green. In the OPD, we don't have glasses.
Yes, ma'am.
Major.
Ma'am, we can use the red color lenses we have on a trial frame and then we can conduct the test.
You don't have your glasses or see. So with the pencil or any pen you can use. Roughly you can assess if you want to have maximum good assessment. Roughly you can assess with your pen only.
Yes, ma'am.
And torsional image you have not mentioned.
I just want you to explain the crossed and uncrossed diplopia once again.
Okay, sir. Sir, when the eye is in esotropia, the eyes turn inwards and the ray of the light which is coming from the object is falling on the nasal part of the fovea. And so, sir, the image, it subtends to the temporal side of the eye. And so the image is formed on the temporal side. And sir, object, and there is no crossing of the object and the false image which is perceived. So it is an uncrossed diplopia. And sir, in exotropia, the image is forming on the nasal side because the light is falling on the temporal side. And so there's a crossing of the object and the image perceived. It is a cross diplopia.
Crossing, basically, then you mean to say that
crossing of both the lines, sir.
Yes, crossing
Yes, sir.
means that the image of the right eye is falling on the left side of the object.
Yes, sir.
And image of the
left
eye is falling on the right, on either on
Yes,
the image
sir.
on the right side of the left eye. Is
Yes, sir.
seen. And then the diplopia chart which you showed, which had maximum separation in the
dextroversion.
But the separation reduced in the up and the down gaze.
Sir, it is due to the unopposed action of the eye.
No,
unopposed muscle of the
but
action.
do you think then the say dextro elevation and dextro depression,
Sir,
the muscle action would change so much that say if you are talking about say medial rectus being malfunctioning,
yes, sir,
right? This is what you said in that
Yes, sir.
patient. Although that is not physiologically possible because medial rectus and the inferior rectus, they are supplied by the same nerve. So you would not have isolated medial rectus, medial and the superior rectus. So medial rectus would not be involved isolatedly, very difficult to have that. So if the medial rectus is involved in the dextro elevation and dextro depression, does it get strengthened because the diplopia decreases?
No, sir. It is used mainly to find out that which muscle is more affected.
No, but then
So
the diplopia charting would show the same separation in the up gaze and down gaze as it is showing in the horizontal gazes.
No, sir, it will not because the primary action is in dextroversion.
No. You have to look into the real life situations.
Okay, sir.
The diplopia charting is for real life situations, and real life situations are limited. So if you talk about a sixth nerve palsy, that's more commonly encountered. The primary horizontal gaze separation would remain same in the up. Say if it was a right lateral rectus palsy, you will have maximum diplopia in the dextroversion. So dextroversion, dextro elevation, and dextro depression will have same separation. It will not change.
Okay,
because even when talking about abduction, this muscle still remains the maximum contributor to that movement.
Thank you. Thank you, ma'am.
Dr. Asmita Singh, she under the mentorship of Dr. Vijay Gupta from Yes, because I don't know anything about macular OCT. I hope I'll understand after your presentation.
Okay. Good morning, everyone. Today I'll be briefing macular OCT, its interpretation and application. So OCT is a easy, non-invasive, quick reproducible procedure which we can do easily in an OPD, and it tells us about the cellular level of the retina, so we can literally call it an optical biopsy. In this image we can see the comparison of histology and retinal layers. So there are various scans, but most important are the raster scan, which gives us high definition images by the parallel scans, and radial scan, which tells us about the relationship between the fovea and the lesion. 3D scan, which gives us typographical maps and volumes about the lesion. Reading a scan, this is a normal macular OCT scan in which we can see all the layers which are hyperreflective and hyporeflective on normal basis. Various zones can be seen in this OCT. So when we read a scan, we first look at the patient particulars and the side of the eye. In this image, we can see the follow-up of a patient is seen. So it is very important tool for follow-up of the patient when we are treating the patient. And there are various layers which are normally hyperreflective. These are the layers. And other than that, we are looking at a drusen, PED, ERM, CNVM, scars, hard exudates or images as seen in these images. Normally, hyperreflectivity is shown by nuclear layer and ganglion cell layer. Other than that, we are looking at intraretinal fluid or subretinal fluid. For an OCT, we will analyze it qualitatively or quantitatively, in which we will look at the location, form, structure, identification of anomaly, and thickness of retina and macula, as it is directly associated with the visual acuity which we are actually dealing with while treating a patient. So here are some common macular conditions like vitreomacular interface disorders, which are hard to pick up clinically as most of them are asymptomatic, but on OCT we can easily diagnose them and classify them as seen in this example. Adhesion and traction can easily be differentiated on an OCT but not clinically. Epiretinal membrane grouping and classification can be done using OCT, according to which the treatment protocol can be decided for the patient. Macular hole confirmatory diagnosis is done by OCT, and various prognostic indices can be calculated using OCT, according to which we can plan the surgery and visual outcome of the patient. In retinal vascular diseases, retinal thickness assessment, patterns of the macular edema, deciding the protocol of treatment, quantification and monitoring of the patient can be done using OCT. Here in this image, we can see the type of macular edema changes our primary treatment protocol for the patient. In vein occlusive diseases, we can see the prognosis of the patient, and it is very important tool to show the patient that how the treatment is working while follow-up. In CRAO, according to the phase of the arrival of the patient, we can decide the treatment, which can be done using OCT. In cases of AMD, dry AMD is solely diagnosed on the basis of OCT. Even a small geographical atrophy and a small island of vision is also important in the cases of AMD, which can be seen only on OCT. And in exudative AMD, the type and location of the fluid and the layers involved is seen only in the OCT. Here we can see the follow-up of the patient post anti-VEGF injections. In CSCR, the extent nature of the SRF and the follow-up of the patient, the response to the treatment is also done using OCT. In cases of myopia, staphylomas, hemorrhages, scars or missed CNVMs can be seen only using OCT, as it is very hard to see clinically due to the high contrast of the fundus. And type of foveoschisis, retinoschisis if present, and planning further for the surgery is done on the basis of OCT and clinical basis. Solar retinopathy if arrived early.
Time is up. Yeah.
Ma'am, can I conclude?
Yeah, sure.
So OCT is very important tool, as it is used for confirmation of the diagnosis. We can classify the diseases better, and planning the intervention for the disease, monitoring treatment and progression of the disease, prognosis, and very important educative tool for the patients. Thank you. So OCT is optical coherence tomography.
All right, thank you.
Thank you, ma'am. Thank you.
So, Dr. Akshika is here. She is going to teach us about the gonioscopy, and she is from SN Medical College, Jodhpur, and her mentor is Professor Arvind Chauhan. So, Akshika, we are looking forward to learn the gonioscopy from you.
Good morning, everyone. I am Dr. Akshika Dhamija from SN Medical College. Today, we are going to learn about gonioscopy. What is gonioscopy? Gonioscopy is biomicroscopic evaluation of anterior chamber angle using slit lamp, or without slit lamp we can use direct. Principle: Why we can't see angle without any lens or simply? Because light from angle structures undergo total internal refraction, because refractive index of cornea is more than refractive index of air. But when we place a gonio lens, refractive index of gonio lens is almost equal to refractive index of cornea. Therefore, total internal reflection is eliminated and we are able to see angle structures. Most important, which I am going to teach first, is how to clean the lens. That's soak in 2% hypochlorite solution for 5 minutes, followed by thorough rinsing in sterile saline, then air drying. Technique of gonioscopy. As a PG student, we must know how to do gonioscopy. Learning angles and diagnosis we can learn with time, but it is important technique of gonioscopy. First, low ambient illumination is required as pupil size affects grading of angle. We should explain the procedure to patient and make patient comfortable on slit lamp. A drop of local anesthesia is instilled, coupling fluid is placed. Ask the patient to look upward, hook the lens in lower fornix and ask the patient to look straight. I have given a picture. This is the way we should do gonioscopy. The methods of gonioscopy, different types of gonioscopy are direct gonioscopy, which we do using Koppe lens. C, the image C is Koppe lens. Indirect gonioscopy are two types. We can do with indentation and without indentation using Goldman 3 mirror, Posner 4 mirror or Sussman 4 mirror lens. The image B is Goldman 3 mirror lens. These are the angle structures which we must learn. Ciliary, first iris root, ciliary body band, scleral spur, pigmented trabecular meshwork, non-pigmented Schwalbe's line. Most important is to identify Schwalbe's line. We can identify Schwalbe's line by corneal wedge. You can see both the lines of the slit lamp will meet at a place that will give you Schwalbe's line if we are not sure about it. We have to differentiate first of all between open angle and closed angle. In open angle, on left side image, we can see all the layers of angle. But in right side, closed angle, we are not able to see. In slit lamp image, ASOCT image also, we can see that angle is closed. This is Schaffer's grading. Grade 0 is closed, and as we move forward, grade 1, grade 2, grade 3, grade 4, angle opens and less chances of occlusion are there. This is a simple diagnosis, double hump sign. This is seen in plateau iris, most prone to closed angle glaucoma. This is a patient of trauma. We have seen cyclodialysis. This is the image, blood in anterior chamber. We can see the angle, there is blood in the angle. Okay, thank you.
Thank you, ma'am. So, if
can you explain what is total internal reflection?
Sir, because of critical angle, the light goes from internal structures. Light gets reflected back into the eye, so we are not able to see. When we
what is the critical angle? Because
43 degree is the critical angle of cornea iris cornea interface. When we put gonio lens, that angle is increased, so total internal reflection is eliminated.
Thank you.
I'll ask something.
Yes.
What's the coupling agent you are using?
Ma'am, we are using viscoelastic mostly.
Okay.
We can also use CMC, or if it is direct lens, we don't need. In some lenses, we don't need coupling fluid. Posner lens, Sussman lens, they don't need coupling fluid because their curvature is same as that of cornea, so coupling fluid is not required.
Okay, thank you.
So next I invite Dr. Anirban Pradhan under the mentorship of Dr. Nikhil Agrawal from AIIMS Jodhpur, and he'll be teaching us deciphering dilemma of optic neuritis.
Good morning everybody. I am Dr. Anirban from AIIMS Jodhpur, and we are today going to learn how to decipher the dilemma of optic neuritis. So why it is the dilemma? So because optic nerve swelling can be due to variety of causes, and all forms of disc swelling share similar pathology, and we need a correct clinical approach for correct differential diagnosis. So let's see a case, a 20-year-old female, sudden onset vision loss and with a unilateral disc edema. So what is the cause and how to proceed? So first of all, we need to make a mind map. So if we see a disc edema, we must differentiate it between true disc edema and pseudo disc edema. In true disc edema, the margins will be blurred and the vessels will go through the substance of the disc. While in pseudo disc edema, the margins will be sharp and the vessels will go over the top. So when after differentiating between true and false, true and pseudo, we will separate into optic nerve pathology or general medical condition or raised ICT. If it is optic nerve pathology, there will be common features like loss of vision, loss of contrast, color vision, there will be RAPD, and the fields do not respect vertical meridians. In general medical condition, there will be appropriate systemic findings. If there is raised ICT and there is obstruction of vision, do an MRI. If there is space occupying lesion, refer to neurosurgery. If there is high CSF opening pressure, it is IIH. If there is normal vision and there is systemic features, it can be meningitis or encephalitis. After making this, we will now go to salient features of each of them. Starting with optic nerve pathologies. First is optic neuritis. There is itis, means there is inflammation of optic nerves. So features of the optic nerve pathologies will be there like loss of color vision, RAPD, field defects, and if it generally associated with MS, so there will be heat sensitivity known as Uthoff sign. And in ischemic neuropathies, ischemia means there is some infarction. So vision loss is sudden and there is no pain with ocular movements. It can be arteritic or non-arteritic. In arteritic, there is a thrombus in short posterior ciliary arteries. So generally the disc is chalky white and there is late fill-in choroidal phase if we do a FFA. In non-arteritic, there is generally crowding at the disc. So there is a compartment syndrome. And we see there is sectoral disc edema. And in FFA, there is segmental disc fluorescence. Okay, so now if there is, suppose there is tumor in the orbit, so there will be proptosis, restriction of ocular movements. In hereditary optic neuropathy, it is heredity. It is generally due to mitochondrial DNA mutations. So we will see telangiectasias in the vessels, in the optic disc. In toxic optic neuropathy, toxic, it means it is due to various toxins and there will be systemic symptoms. In CRVO, there is venous occlusion. So there will be stasis. In the stasis, there will be dilated and tortuous veins and it will go to peripheral. Malignant hypertension, raised blood pressure, and it will be grade for hypertensive retinopathy. Papilledema, visual acuity, color vision, ocular motility, all remains normal. Fields will be normal features, FFA to see filling defects or any leakage, CT scan for tumors, MS for periventricular plaques, CSF for oligonuclear bands in MS. So returning to our question, we see there is features of the optic nerve pathologies, RAPD, contrast sensitivity, and the clincher is MRI, and we can come to the diagnosis. It is optic neuritis, typical type. Thank you. In the typical optic neuritis, it is generally demyelinating type. So their features are generally RAPD is present. It is unilateral. Loss of vision is in hours to days, and some features of demyelinating features are mainly present. While in atypical, it is many other causes are there. It can be bilateral. It can be neuroretinitis, parainfectious, non-infectious causes. Sarcoidosis, they may be coming in atypical types. Yes, there is a difference because in typical type, we generally give IV methylpred and steroids have good response. While in atypical type, we have to find the exact cause. And suppose it is infectious, we have to give specific treatment to the specific cause. So first we have to differentiate between typical and atypical.
So if there is a lady 8-month pregnancy and you see disc edema, so what do you suspect and what will be your course of action?
First of all, in pregnancy, we have to in pregnancy related pregnancy induced hypertension may lead to raised disc edema also. We have to check it is bilateral or unilateral. After checking it, we have to find the exact cause, then we will treat it accordingly. Generally not, we do not give it. We wait for the delivery and then. No, ma'am, but I will.
Okay, thank you, Dr. Anirban.
Thank you, ma'am.
So next I invite Dr. Darshana Parihar, and she will be speaking to us on the current strategies and practices on corneal blindness and eye banking under the mentorship of Dr. Rakesh Porwal from JLN Medical College, Ajmer. Over to you, Dr. Darshana.
Good morning, class. So today I'll be teaching you about a very interesting topic, which is corneal blindness, eye banking, current strategies, and the best practices. So we all know that corneal blindness is the leading cause of blindness globally and in India. Can you tell me about the major causes of corneal blindness in India? Anyone? So we all see a lot of patients of corneal ulcer, infectious keratitis in our ward every day. And the other major causes are corneal trauma, pseudophakic bullous keratopathy, chemical injuries, keratoconus, infective conditions like trachoma, and hereditary corneal dystrophies. So let me tell you about the Transplantation of Human Organ Act. So it was implemented in 1994, and under this act, cornea is a tissue and not an organ. It was modified in 2011, and under this, the relatives are also allowed to provide consent, and also the trained technicians are allowed to retrieve the cornea, not only the trained medical practitioners, registered medical practitioners. So what are the consent systems for eye donation? One is opt-in and another is opt-out. So under the opt-in system, we have to voluntarily donate the cornea, okay? And under the opt-out system, everyone is considered a donor except those who opt out. So it is not followed in India. Now, what are the two ways to procure the corneal tissues in India? One is voluntary eye donation, and other is the hospital cornea retrieval program. So under voluntary eye donation, the deceased family has to inform the eye bank about the death of the person, and the trained technician goes and collects the cornea. And what about the hospital cornea retrieval program? In this, a trained grief counselor is assigned in every hospital. So whenever a death happens in the hospital, the counselor attends the family and counsels the patient for donation. So what is the advantage of HRCP program? The advantage is that we already know the medical history of the patient. Now, what is an eye bank? It is a non-profitable community organization, and the functions of it are tissue harvesting, evaluation, and tissue preservation and distribution. Its function also involves research and public awareness. In India, there is a 3-tier system which is followed. It includes eye banking training center, eye bank, and eye retrieval centers. So who can donate? Person of any age and sex can donate. Spectacle wearers, post-cataract surgery patients, patients with diabetes and hypertension, and patients of blindness of retinal or optic nerve origin can also donate. What are the contraindications of eye donation? So there are ophthalmic and medical contraindications. They include any previous intraocular or anterior segment surgery, corneal pathologies including opacities, keratitis, and dystrophies, and any retinoblastoma or intraocular malignant tumors, active intraocular inflammation, and the systemic conditions can include active hepatitis, AIDS, rabies, rubella, bacterial or fungal infections, or any active leukemias and lymphomas. So this is a Conan specular microscope. It is used for donor corneal tissue evaluation. You must have seen it in our eye bank, and we all must know how to operate it. So this is eye bank preservation media. It is divided into 3: short-term, intermediate term, and long-term storage media according to the duration for which the cornea is stored in it. Now I want you all to tell me about the contents of these media in tomorrow's rounds. Thank you.
You wrote any intraocular surgery is a contraindication. So a patient who's gone a cataract surgery done, can't he donate a cornea?
Sir, patient who had undergone cataract surgery can donate the cornea.
So only specific?
Yes, sir. Only specific intraocular conditions. Like, ma'am, anterior segment surgeries, like if the patient has undergone refractive procedures like LASIK, ma'am, that procedures are a contraindication to that. Okay, ma'am. Ma'am, to the patient, to the eye bank, ma'am, there is a common platform, ma'am. There is a app also, and ma'am, there is a group which is made. Ma'am, Rajasthan Ophthalmological Society has a eye bank group. So we just, if we need a cornea, we put our request there, and as soon as it is available, it is made available to our hospital. Yes, ma'am. Ma'am, we tell about that we need it for therapeutic or optical purpose. So according to the counts, endothelial cell counts, it is provided. Yes, ma'am. There are grading systems, ma'am, according to the endothelial cell densities, and ma'am, according to the polymegathism and polyhexanal cells, ma'am. It is graded according to that. Thank you, ma'am.
Thank you, Dr. Darshana. That was very enlightening talk. Now I invite Dr. Ekta Karhana from GMC Kota, and under the mentorship of Dr. Jayashree Singh, she will be speaking on management of vernal keratoconjunctivitis. What is new?
Good morning, everyone. I'll be teaching about the vernal keratoconjunctivitis. It is also known as a spring catara. It is allergic conjunctivitis, usually bilateral, recurrent, and self-limiting and seasonal in nature. It includes the clinical features of marked burning and itching sensations that is intolerable and more in case of palpebral form of the disease. And other signs and symptoms include the photophobia, lacrimation. Usually it has astringy and the ropey discharge and heaviness of the lids. Etiopathogenesis, there is a T helper cell to lymphocyte alteration, and there is since it is allergic in nature, so exaggerated IgE response to the common allergens. Predisposing factors include, it is most commonly in the age group of 4 to 20 years of age, and commonly in boys because they play more in outside. And season, mostly in the summer, and the warm weather, also known as warm weather conjunctivitis, mainly in the tropic seasons. The palpebral form of the VKC usually occurs in the upper tarsal conjunctiva of both eyes. Typical lesion is the presence of hard, flat-topped papillae arranged in a cobblestone or a pavement to stone fashion. Usually white ropey discharge is there. In case of bulbar limbar form of VKC, there is red triangular congestion, gelatinous thickened accumulation, and Horner Tranta spots are seen most commonly. In case of corneal involvement in VKC, known as vernal keratopathy, there may occur punctate epithelial keratitis, usually in the upper cornea, and it stained with the fluorescent dye. Second, it can cause ulcerative vernal keratitis. Shield ulceration can occur, and vernal corneal plaques can occur, and subepithelial scarring, the ring-shaped scar it can cause, and pseudogerontoxins. This is a picture from OPD with a child that was 11 to 12 years of age, having shield ulcer in one eye, and in the other there was Horner Tranta spots were present. And it was presented with a history of around 4 to 5 years. Talking about the treatment, we can give the topical anti-inflammatory therapy. The mast cell stabilizers, we can give eye drop sodium chromoglycate 2% 5 times a day. Dual action histaminics, that is having antihistaminic action, and the mast cell stabilization के form में we give olapatadine 0.1% BD, or ketotifen we can also give. In case of NSAIDs eye drops, we can give eye drop ketorolac tromethamine 0.5%. Talking about topical corticosteroid, we should give low potency topical steroids because they can cause steroid-induced glaucoma. So we can give fluoromethalon 0.1% 4 times per day, and we have to taper it weekly. Or we can use loteprednol 0.2%. Among the immunomodulators, in the resistant cases, we can give immunomodulators. Eye drop cyclosporin can be given 0.1% to 0.5% to 1%, and eye ointment tacrolimus 0.03% can be tried. Topical lubricating and mucolytics agent should be added with these treatment. We can give CMC 0.5%, and in the resistant cases we can give mucolytics eye drop acetylcysteine 0.5%. The resistant cases we should also give the systemic therapy, and if the papillae are very large, they are causing keratopathy, so we have to treat that large papillae by using supratarsal injections or cryoapplication or surgical excisions. And apart from that, we have to guide the patient or their parents about the general measures, using dark goggles, avoiding going in the sunlights, and using doing cold compression. If there is vernal keratopathy, then for punctate epithelial keratitis, no treatment required. For large papillae, we have to surgically excise, or we have to do the...
Yeah, your time is up. Okay. So, if you have any question, otherwise, next, Dr. Kiran. Yeah.
Then, atopic. It will exaggerate. Thank you.
Okay, so next we have Dr. Kiran Yadav, and she will be presenting on diabetic macular edema, recent trends in management. And she is from AIMS Jodhpur, and her mentor is Dr. Kirti Jaising.
Good morning, everyone. I am Dr. Kiran. Today we'll discuss about the recent trends in management of the diabetic macular edema. Diabetic macular edema is a sight-threatening condition, and globally, if we see around 21 million patients have diabetic macular edema, and India is at rank second in the global diabetic epidemics, which shows it's very important to manage it. Pathophysiology behind it is inner blood-retinal barrier dysfunction, outer blood-retinal barrier dysfunction. So, as it is a metabolic syndrome, we have to manage it both by systemically and by local treatment. So, when to treat the patient? If visual acuity loss is more than equal to 5 letters ETDRS, or there is a centrally involved macular edema. So, as we decide to treat the patient, what all questions comes in our mind? So, anyone? Okay, let's treat. How to treat is like choose the correct regime, choose the correct therapy, choose the correct regime, when to switch for the alternative treatment, when to stop, and what to look for the prognostic, when to look for the prognostic factors. Now, let's see, on the basis of diagnostic modality, we choose our treatment, like if there is central macular edema with neurosensory detachment, we choose anti-VEGF or steroids. If there is a cardiovascular event less than 6 months, we prefer steroid. If there is VMT, taut posterior haloid, we prefer surgery, that is PPB plus minus ILM peeling. If there is a refractory edema, we do wild field angiography and we choose laser or surgery. On the basis of FFA, if there is a focal leakage, we give focal laser. If there is a diffuse leakage, we give anti-VEGF followed by the grid laser. And if there is a ischemic maculopathy, we can try anti-VEGF or the laser. Now, how to choose the regime? If we choose the fixed regime, we give monthly injection. If we choose the pro-Renata regime, we give initially loading phase followed by the monthly injection till the normalization of the foveal contour and the visual acuity more than 6/12, and then we do the monthly follow-up. Treat and extend regime, initially give the loading dose. After that, we extend it by 2 weeks if there is a no activity, or decreases by 2 weeks if there is an activity in on OCT. So, when to switch for the alternative treatment? When there is no change in the status of the visual acuity or the central macular thickness for the consecutive monthly injection, we look for the another anti-VEGF or another treatment. So, when to stop the treatment? Suppose a 56-year-old diabetic female presented to you in OPD with both eye diminution of vision. On examination, BCVA is in both eyes 6/9, IOP is normal, fundus shows severe NPDR, and CMT in right eye is 450, left eye 560, and there is after giving 5 injection in right eye and 6 injection left eye, there is no improvement. What will you do? What will you do? Change anti-VEGF, stop the treatment, steroid or surgery? Yes, stop the treatment. Here's the OCT biomarker showing the prognostic indicator. Most important were drill, showing the ellipsoid zone disruption. Other one is showing outer retinal tubulation. Artificial intelligence used for screening. We use mechanical learning and deep learning, both used for classification, and deep learning is also used for checking the response after treatment. New modalities coming for anti-VEGF are faricimab, which is biphasic intravitreal anti-VEGF indicated in DME and AMD. Port delivery system, where we fit in the sclera, a delivery system which is under phase 3 trial. Thank you, everyone.
Thank you, Dr. Kiran.
Any role of PRP or pan-retinal coagulation would you do for macular edema?
Yes, sir. Sir, if there is a diffuse leakages there, we can go with this pan-retinal photocoagulation, sir. Yes, sir.
Okay, so next we have Dr. Pavan Kumar, and he'll be talking on fungal keratitis. What are the key points in diagnosis and management?
Good morning, everyone. Today we are going to discuss about the lab diagnosis and management of fungal keratitis. But first of all, we should know why we want to diagnose. So the answer is simple: to differentiate fungal keratitis from bacterial and viral keratitis. Fungal keratitis clinically can be distinguished on the basis of feathery margins and satellite lesions and hypopyon, which is immobile and concave in shape. Lab diagnosis involves direct microscopy, fungal cultures, PCR, and confocal microscopy. But before going to the microscopy, we should obtain corneal scrapings. It should always be obtained from the leading edge and from the base of the ulcer. And for obtaining corneal biopsy, corneal scraping, we can use surgical blade 11 number, or Kimura spatula can also be used. 21 gauge needle, calcium alginate swab, or diamond tip burr can also be used. Coming straight away to the direct microscopy, here the role of microbiologist arises. So, direct microscopy involves the KOH mount, Gram stain, Giemsa stain, gomorimethymine, and chalcofluor white, which is a fluorescent stain. If the KOH mount comes out to be positive, we start the patient on natamycin, and we further wait for the reports by the microbiologist. Here we can go for the cultures, and the most common culture plate used is the SDA agar, or blood agar plate can also be used, and chocolate agar plate can also be used. But what if the scraping comes out to be negative? We go for the corneal biopsy, and anterior chamber tapping can also be done. Histopathology can also be done. It shows the fungal hyphae which are perpendicular to the corneal lamella. Limbal infiltrates and abnormal degenerated hyphae can also be seen. What are the neo-diagnostic modalities? Immunofluorescence staining, electron microscopy, confocal microscopy can also be done, and PCR can also be used. Coming straight away to the management part, it involves the medical and the surgical management. So we start the patient on natamycin eye drops 1 to 2 hourly, and if there is stabilization and improvement seen within 48 to 72 hours, we reduce the frequency according to the response. And after resolution of infection, we will continue the treatment at least for 2 weeks. But if there is no resolution, we will start the patient on amphotericin or voriconazole. And if still there is no improvement, we go for intrastomal and intracameral ampho B and voriconazole eye drops. Systemic antifungal is started in cases of deep keratitis, scleritis, and endophthalmitis. So these are the natamycin eye drop deposits seen on the cornea, which can the patient sometimes get worried that there is no improvement, but we should always counsel that these are the natamycin eye drops. Coming to the surgical management is done when there is failure of the medical management or there is deep ulcer, and we can go for early deep anterior lamellar keratoplasty. These are the other modalities. Conjunctival flap can be done. Corneal graft penetrating keratoplasty, cyanoacrylate adhesive over the perforated corneal ulcer can also be used. What are the take-home points? Fungal keratitis should always be suspected after any history of trauma by vegetative material or foreign body in the eye, any progressive unresponsive corneal ulceration, and corneal scraping should always be done in any case of corneal ulcer patient and should be sent for Gram stain and KOH mount. So it's a combined effect of the microbiologist and the ophthalmologist in treating the fungal keratitis. Thank you. Ma'am, we can see the hypopyon, which is immobile and concave in shape, and sir, ma'am, non-sterile, and the satellite lesions are also being observed along with the feathery margins of the ulcer.
Okay, thank you, Dr. Pawan. So next we have Dr. Sana Qureshi, and she'll be talking upon the role of amniotic membrane transplantation in chemical injury, and she is also a junior resident from Jailand Medical College, Ajmer.
Good morning, everyone present here. Today we are going to discuss about role of amniotic membrane transplantation in ocular chemical injuries. What is chemical injury? It is a true ocular emergency, require immediate intervention, and it is majorly caused by alkalis followed by acids. Alkalis injury are the more harmful because it lead to the severe and deep rapidly penetration because of liquefactive necrosis, whereas acid injuries are the less harmful because of coagulative necrosis. The injury are the more localized and less severe. Immediate management following the chemical burn are to remove the offending agent and restore pH, because it is the cornerstone in managing the chemical burn. So we use any non-toxic solution in case at the scene site to prevent further damage. So we can use tap water, but in a hospital setup we should use BSS in place because it maintain corneal endothelial count and function, and maintain the corneal clarity. So after that, we control inflammation by topical steroids, topical antibiotics, cycloplegics. In case of alkali burn, we should use topical anti-glaucoma drugs. We promote ocular surface healing by vitamin C, systemic vitamin C tablets, because it acts as a cofactor in a collagen synthesis, and doxycycline tablets capsule, which has besides the antimicrobial effect, it has a matrix metalloprotease enzyme inhibitory effect also. We use preservative-free artificial tears. So after the immediate management, in the case of moderate to severe burn, we manage the patient by surgical intervention by debridement the necrotic tissue, because it acts as a source of infection and inflammation, and we transplant the amniotic membrane, and it should be done within 7 days following the injury. So what is amniotic membrane? It is the innermost layer of the placenta that is delivers oxygen and nutrient to the growing baby, and it is obtained from the consenting donor, which is negative for any infectious diseases. Amniotic membrane is available in a two form, that is dehydrated and a cryopreserved form. Dehydrated form, the structural integrity is drastically altered, and it is stored at the room temperature for 4 to 5 years, where cryopreserved form is more preferred because it is stored at minus 80 degrees centigrade in a Dulbicos modified Eagles media, and it is used for 1 to 2 years. The commercial available form is AmnioGuard, AmnioGraft, and Procera. Why amniotic membrane is used as a surface reconstruction? Because it acts as a basement membrane. It promotes the growth of epithelial progenital cells, including stem cells. It inhibits scar formation by inhibiting myeloproliferative enzyme activity. It has an antimicrobial and an anti-inflammatory effect. It stabilizes ocular surface, prevents similifron formation. As it is pre-soaked in an anti-infective agent, it has a long-term drug delivery effect also. It helps in wound healing by inhibiting the matrix metalloprotease enzyme, which causes destruction of collagen, and has an immune privilege because it does not express any MHC antigen over it. Amniotic membrane transplantation techniques, that is, we transplant the amniotic membrane in 3 forms, that is inlay, overlay, and a combination of these two, that is known as sandwich technique. It's a small video showing amniotic membrane transplantation overlay technique, in which we use appropriate size graft cover the epithelial defect, and followed by larger size graft which cover the whole cornea and adjacent conjunctiva. We can also use biological tissue adhesive in place of this. Another small video showing amniotic membrane cover the entire ocular surface from lid margin to the palpebral conjunctiva, bulbar conjunctiva, and cornea. This technique is used in a severe case of ocular chemical burn. The other indications are to after the removal of limbal dermoid, we can use in a surface conjunctival reconstruction after the similifron release, and an ocular cicatricial disease like pemphigoid. What is complication? That is during the processing, that is lack of sterilization during obtaining, processing, and preservation of amniotic membrane, persistence of infection and inflammation, shrinkage, dislodgement, and disintegration of the graft, early failure to achieve intended effect. The clinical trial which occur in a hospital, patient come with a history of exposure to the burning coal, and this is a great for ocular chemical.
Okay, thank you, Dr. Sarna. If you have any questions, I'll request Dr. Shanti Priya to be ready. Yeah. Okay, so Dr. Shanti Priya will be speaking on basic terminologies in strabismus, and she is from Shankara Eye Hospital, Jaipur. Her mentor is Dr. S. Vishweshwaran.
Good morning, class. Topic for today is basic terminology of strabismus. First of all, I hope every one of you sitting here can see me singly and my hand single. If anybody sees it double, please raise your hands. Single? Yes or no? Okay, so it means we have the intact binocular single vision. That is characterized by the ability to fuse the images from two eyes and to perceive the binocular depth. There are 3 grades of the binocular vision. One is simultaneous perception, second is fusion, and third is stereopsis. I am giving you the example as I am standing behind this dais. The 2 macula of your eyes are seeing me singly, that is the simultaneous perception. You can make out that there is a dais and I am standing behind the dais, that is the fusion, that the 2 things are together. And the stereopsis, that there is a distance between the dais and me. That comes out to be stereopsis. Now the corresponding points, the areas of the each retina that share the same subjective visual direction are known to be known as corresponding points. The 2 eyes of you are seeing me together as a single point. The different corresponding points will be the 2 fovea of the 2 eyes. Next is horopter.
That is an imaginary plane in the external space, all points on which will stimulate the corresponding retinal elements, so therefore seen as singly. And next is Pannon's fusional area, that is zone in the front and behind of the horopter, in which the object simultaneously slightly non-corresponding points on the two retina. As this image, there is a horopter and the Pannon's area has been described. Just to give you a quick example, there are three types of a student in a class. Student number 1, who attends all the classes, always there, always reads whatever the teacher is teaching, that comes under horopter. She and he will always pass. There will be a clear, distinct image that will be following on the fovea of the two eyes. The second one is the Pannon's area. Students who sometimes bunk classes, sometimes attend classes, but in the end, who are very, very important and they read all out the important subjects, they comes under the Pannon's area. The images that will be formed in the Pannon's area will be adjusted and still will be able to see image as one. And third are the areas that would be the students who never pass, who never come to the class, that will causing us the diplopias. Next is orthophoria. The perfect ocular alignment in the absence of any stimulus or for the fusion will be considered as optophoria, which is a very rare term to be seen. The heterophorias, the tendency of the two eyes to deviate. If it is an inward deviation, that will be esotropia, and if it is an outward deviation, that will be termed as exophoria. For the tendency of the eyes to break, there will be the breakage of the fusion is to be present. Tropia, that is the manifest deviation in which the visual axis of the two eye will not intersect at a point of fixation. That may be horizontal and vertical. In horizontal, it will be exotropia, the outward deviation, esotropia, the inward deviation, hypertropia, the upward deviation, and the hypotropia, the inward deviation. This is a diagram that is showing the images of eso, exo, and hypertropias. Next is fusional vergence, the disconjugant movements to overcome the retinal image disparity. If I am seeing this dice and I am seeing that girl sitting at the last, there will be the movement in order to see her, I'll be diverging my eyes, that will be known as fusional vergences. Suppression, the active inhibition by the visual cortex of the image from one eye when the both eyes are open will be known as suppression. And abnormal retinal correspondence when the point focused on one fovea will not corresponding on the fellow eye, that will be known as abnormal retinal correspondence. Thank you.
Is there something called as retinomotor value?
Sorry, sir?
Retinomotor value.
Yes, sir. The difference in which the two images will be seen as single, but there will be the difference on the images formation on the retina. Ma'am, it can be diagnosed with the help of prism tests. Ma'am, when we will be performing the 4-base prism test, normally there should be the outward movement of the eye to see the two images together. But if there is no movement is seen, then the case is... Ma'am, there can be the presence of strabismus in the patients of abnormal retinal correspondence. Diplopia may or may not be present. Necessary. No, ma'am. The eye focuses and they are maintained to maintain the binocular single vision. There will be no diplopia.
Okay. Thank you, Dr. Shantipriya. Now I invite Dr. Simran Kaur to talk upon the physiology of aqueous humor dynamics, and she is from GMC Kota. Her mentor is Dr. Meenal Gupta.
Good morning, everyone. Today, my topic is on aqueous humor dynamics. Aqueous humor is a clear, colorless, watery solution which helps in the maintenance of intraocular pressure, metabolic role, optic function, and clearance function. Volume of aqueous is 0.3 ml, out of which 0.25 ml lies in the aqueous chamber and rest in the posterior chamber. Aqueous humor production is by the ciliary process of pars plicator. Formation process involve diffusion in the direction of concentration gradient, ultrafiltration in response to osmotic gradient or hydrostatic pressure limited by size and charge. Secretion, it's an active process which require ATPase against the concentration gradient. Now the fluid has to pass through 3 layers of ciliary process. First is through the endothelium to the stroma, then to the pigmented layer, and then to the non-pigmented layer. Now, steps of aqueous formation. First, there occur a formation of stromal pool. Then there is an active transport of the stromal pool and a passive transport from the non-pigmented ciliary epithelium.
how this formation of stromal pool occurs. From capillaries, it goes into stroma, and then it lie behind the tight junctions of the non-pigmented epithelium. Now this fluid which is formed, they goes into the anterior chamber. Now the aqueous humor, which lies just below the cornea, it is cooler because of evaporation. So the fluid become dense and they go downward, in contrary to the aqueous fluid which is present above the lens, which is warmer. So because of this temperature gradient, there is a conventional flow of the aqueous humor. It is drained through two routes, uveoscleral and trabeculae route. Now uveoscleral outflow, that is 10 to 20% of the drainage, which pass from anterior chamber to the ciliary muscle, then to the suprachoroidal space and directly to the venous circulation. In the trabeculae outflow, maximum drainage occurred through this route. Now it passes through the uveal meshwork, then to the corneoscleral meshwork and juxtacanalicular tissue. From there, it goes to the inner wall of the endothelium of the Slem's canal, going directly into the episcleral vein through the aqueous vein, or by the indirect route from the intrascleral plexus, which is 3 in number. Then from episcleral vein, it goes into the systemic circulation. During diastole, there is decrease in the intraocular pressure. Because of that, the trabeculae meshwork, it is pulled inward. So it creates a negative pressure there. Because of that negative pressure, the fluid gets sucked into the Slem's canal. In this, during the systole, there is increase in the intraocular pressure. Because of that pressure, the trabeculae meshwork, it is pushed outward. Because of that pressure, the fluid goes into the aqueous vein and further into the episcleral vein. Thank you.
We still have 1 minute if you want, if your PPT is left. It's done?
Yes.
Okay, thank you very much. If you have any question.
Yes, sir. Facility of
outflow facility.
Yes, there is a intelligent group of students which is sitting in the front row. As said कि आगे जो बैठते हैं वो ज़्यादा intelligent होते हैं. Bachcha, we'll discuss about this in the next class.
Okay, thank you, ma'am. No question from the ma'am. So very interesting. Now. Now we have Dr. Sophia Chaudhary from Mahatma Gandhi Medical College, Jaipur. Asha, Sophia is not there. So Tapasya Rajpurohit, she'll be presenting upon the approach to a patient with fourth nerve palsy. And she is from AIIMS Jodhpur. Her mentor is Dr. Jyoti Sakarwal. And I request all the speakers to stay back for a group photo at the end with the judges. Okay.
So good morning, class. Today we learn about approach to fourth nerve palsy. Coming to why learn about this approach. So we can see the annual incidence as 5.73 per 1 lakh per year. And from our previous anatomy classes I took, I hope you remember that it is the only cranial nerve to cross completely on the other side, arise from the dorsal aspect, and longest and thinnest of all cranial nerves. Etiology being congenital and acquired. So we'll have a child, 12-year-old child who presented with complaint of upward deviation of right eye since childhood with no other significant history. We'll come back to this after learning the approach. Starting with the approach, so this is the sequence that we follow. Starting from history. So onset, associated signs, chief complaints. This is how a child presents in case of congenital palsy, and that is how an adult presents. So what we have here is left facial hypoplasia and right SO palsy. Why? Because of the head posture that is persistent throughout the ages of the child. In adults, we have torsional or vertical diplopia associated with contralateral head tilt. Please remember, my students, I'll ask this in the end too. So old photographs. So old photographs, why is it important? Anyone? In congenital cases, all through the ages, we'll have the characteristic head posture as seen in this diagram. Coming to squint workup. So squint workup, this is the most important step of squint workup, which is the Parkes 3 steps test. What are the 3 steps? Anyone? Deviation in primary gaze. Second is deviation in levoversion, dextroversion. And third is worsening with the head tilt. Remember. So here we can see, what we can see is in primary gaze, we have left hypertropia, worsening in right dextroversion, and worsening with left head tilt. So we can say right head tilt and left SOP. what I told you earlier is contralateral head tilt. Here the same thing applies, right head tilt and left SOP. Now check the other eye too, especially in case of trauma where in the crossing point is affected. So there will be bilateral SO palsy, wherein we can see bilateral head tilt positive, V pattern, esotropia. These are the salient points actually. Chin depression and greater than 10 degrees of X cycloversion on double Maddox testing. Coming to torsion. So there are two methods, subjective and objective. So Maddox rod and fundus photography, we can clearly see the extorsion, bilateral extorsion. Confuses ocular myasthenia, thyroid eye disease, and other ocular diseases. Coming back to our case, we can clearly see IO overaction, hyperdeviation due to SO palsy, right extorsion in fundus photo, making a diagnosis of right eye congenital SOP with IO overaction. Class 1 NABS classification and therefore our management of IO recession. And these are the post-op photographs. Now a quick recall. Quiz time for my students. Head posture in left SO palsy, chin depression, left head tilt, right face turn. Anyone? Contralateral head tilt. So the answer is right head tilt. Thank you.
Ma'am, why does a contralateral head tilt reduces the vertical deviation, and why the ipsilateral head tilt increases the vertical deviation?
Actually, sir, this is how superior rectus and superior oblique, they work in coordination with each other. So if there is absence of working of one muscle, so there will be unopposed action of the other. So in superior oblique palsy, there will be unopposed elevation of the superior rectus. So in that particular case, there will be elevation and vertical deviation will be higher.
Suppose with
Ma'am, superior oblique causes depression, intorsion, depression, and adduction. Superior rectus causes extorsion, intorsion, abduction. Superior rectus, ma'am, elevation, depression. Superior oblique has primary action as intorsion. Depression also, yes, ma'am.
So in the head tilt, what happens like if the superior oblique is malfunctioning, say we talk about a left superior oblique palsy, the deviation should reduce with the right head tilt.
Yes.
But if you do a left head tilt, what happens to the superior oblique and superior rectus?
Sir, actually there is an unopposed action of the superior rectus that is there.
All right. So that was Dr. Tapasya. And now we have Dr. Vanshika from GMC Kota. And she'll be speaking on OCT biomarkers in diabetic retinopathy. And her mentor is Dr. Ashok Kumar Meena, sir.
Good morning, everyone. Today we will discuss about OCT biomarkers in diabetic retinopathy. Diabetic retinopathy is a vascular disease which affects deep retinal capillaries, and this leads to many vascular changes. And these vascular changes further lead to structural changes in the retina, mainly in the macular region, which can be detected on OCT, that is optical coherence tomography. Now, what are OCT biomarkers? OCT biomarker is a non-invasive technique, helps in refinement of diagnosis, provides near histological assessment of the disease, and helps us to study the disease progression, is reliable and accurate, and is important to assess the functional outcomes of the treatment given to the patient. First is central subfield thickness. It is defined as thickness in the central 1 mm area of the circle of ETDRS grid map. In cases of diabetic macular edema, this thickness increases. So, when the retinal thickness exceeds the stretching capacity of the retina, this leads to damage to bipolar cells. Bipolar cell snap occurs, and these bipolar cells are important for visual transmission from photoreceptors to ganglion cells. And due to this bipolar cell snap, there will be reduced visual signal transmission, and hence visual outcomes will be compromised even after resolution of diabetic macular edema. So, this raises us a question that whether central subfield thickness alone is enough to predict the visual outcome. No, we need other biomarkers. So, the first is DRIL, that is disorganization of inner retinal layers. It means that the 4 retinal layers, GCL, IPL, inner nuclear layer, and outer plexiform layer, are not distinguishable in the central 1 mm of the fovea. Even if edema resolves but DRIL is present, outcome of vision will be poor post-treatment. Next is hyperreflective foci. Hyperreflective foci are formed due to breakdown of inner blood-retinal barrier. Some studies believe that it is due to extravasated lipids, while others believe them to be activated microglial cells. Microglial cells are inflammatory cells, so it is an important inflammatory marker. Sometimes these hyperreflective foci arrange themselves around a cyst in circular manner, giving pearl necklace sign. This is called as pearl necklace sign. Now, how to differentiate this hyperreflective foci from hard exudates? First of all, their size. Their size is less than 30 micrometer. Then there is no backshadowing, as can be seen in this figure, which is present in case of hard exudates. Then its reflectivity is very much similar to RNFL. Now, in patients who are having higher number of hyperreflective foci, it means that there are chances of early reoccurrence of diabetic macular edema. So, frequent follow-ups are needed in these patients and early intervention is also recommended. The next marker, which is also formed due to breakdown of inner blood-retinal barrier, is intraretinal cystoid spaces. And sometimes there is deposition of hyperreflective material in this cystoid spaces, which is composed of inflammatory debris and fibrin, and it is a poor prognostic indicator in diabetic macular edema. Next is bridging retinal processes. These are vertically oriented hyperreflective lines which represents residual neural elements composed of Muller cells and bipolar cells, and if they are absent, it means the vision of the patient will not improve post-treatment. Next is ELM-EZ zone disruption. The health of the outer retinal layers is very important for visual signal transmission, and if these are disrupted, then also visual outcome will be poor. Next is OCT angiography. The benefit of this is that it gives us the view of all the three capillary plexus individually, and no dye is injected in this case. So it is safe in patients who are pregnant or there is renal function impairment, or no risk of anaphylaxis is there in this. The take-home message is that OCT is a good imaging biomarker which is non-invasive. Central subfield thickness, which was regularly believed, has only modest correlation with vision. But the new biomarkers are the robust predictors of vision in diabetic macular edema. Thank you.
Okay, thank you, Dr. Vanshika. Now I call upon Dr. Vignesh Kabra, and he'll be talking on understanding and eliciting visual acuity in infants and children. And he's from Mahatma Gandhi Medical College, Jaipur.
Good morning, everyone. I'm Dr. Vignesh Kabra, resident from Mahatma Gandhi Medical College. Our class for today is about evaluation of visual acuity in infants and children. In this session, we'll skim through the visual milestones and assessment of visual acuity. So before we start, we need to know about visual milestones because they give us an idea for the test that we have to give to the child and the expected outcome. Here we can see that before 3 years of age, a child starts with fixations towards light and then following it favorite pictures. However, after that, they can do our normal visual acuity test and grade it as per them. But what are the challenges faced? They have a sudden change in mood. They have a very low attention span. They have strangers anxiety and inability to understand the need for examination. So we will study a set of 8 rules to collect visual data from our little mischievous humans. Rule number 1, they are very afraid of coats because you have given them trauma of needles. So it's time to become friendly, remove the coat. Next we have to, for ourselves, that is knowing the age is must to provide the right environment for further evaluation. So in infants, they only react to mother. However, after that, they might react to your gestures and dance moves. And for children 1 to 3 years, they are joyful around toys. And after that, they are smart enough to do all your exams. Then we have rule number 3, initiate. The examination divided into 2 types of segments. The sensory motor examination, that is an associative one. Since it doesn't involve any touch to the patient, no interference in doing any work, so the child is, it's a binocular examination, child is happy with it. In a monocular and motility examination, this is the second form. Then we have the sensory motor examination. Let's learn the art in rule number 4. Infants, fixation testing is the first sign, the ability to locate the source of light. And second, we have the CSM method, the central, steady and maintain. Central, the central corneal reflex, the steady movements for nystagmus, and the maintain to rule out the lazy eye. Then we have the optokinetic nystagmus drum, a very vintage and useful instrument to find breaks in the saccadic eye movements to know any nystagmus or and grade the visual acuity. Then the children from 3 to 1 year of age test based on principle of spatial frequency of images. Here we move to rule number 5, That is, it's time for us to be attentive. The teller equity card. In this, there are gratings from black and white on one side and uniform color on the other side. And as they keep on decreasing in cycles per centimeter, as soon as the child loses focus, we record. And in this, we have to check our mistakes in Rule 6 and grade it according to the standard visual acuity test, such as the Snelling's. Here is a video of the LIA grading test that works on the same principle as the teller acuity cards. Then we have the Cardiff test, the vanishing optotype. Outlines graded are faded accordingly in the subsequent cards, and the result is recorded. If you cannot read the last line of this slide, sorry, you haven't passed the Cardiff test. Then children 1 to 3 years of age of the notorious gang, the LIA symbols of apple, house, window, and a ring. Visual acuity is noted as per the Snellen's or Logmar chart. The HOTV testing, and the third, we have the pediatric chart, consists photos of animals, cartoon toys, to keep them engaged in a boring ophthalmologist room. Then for older children, the standard optotypes test plays at a distance of 6 meters or 20 feet, angle of 5 minutes, and graded 6.6. Here we have the Snellen's, the Logmar table, and the Landau C chart. What if the child visual milestone is suboptimal or deficit in cognitive development? Here we have to enable our disabled in Rule 7, that is visual evoked response, and the Steiker test. The Steiker test for young children and retards. Remember, never give up and keep smiling. It's okay to be a grown-up child, and always follow the rules of children. Thank you.
Thank you very much, Dr. Vignesh. And if you don't have any question, then we move on to the next presentation, that is by Dr. Zeba Shaheen, and she'll be speaking on endothelial keratoplasty and update under the mentorship of Dr. Dharamveer Chaudhary.
Good morning everyone, myself Dr. Zeba Shaheen. I'm here presenting the endothelial keratoplasty. We would know about what is endothelial keratoplasty, what are the type, what are the indication, different techniques for the keratoplasty, how it is different from the penetrating keratoplasty, which used to be the only surgical option for the corneal blindness, why we evaluate from DSEC to DMAC. So, endothelial keratoplasty is a surgical technique in which we selectively replace the diseased and dysfunctional corneal endothelium with a functional and anatomically preserved corneal endothelium, which is dissected from a cadaveric human donor cornea. It is a deep lamellar keratoplasty in which the stroma of the recipients is preserved. These are the types of endothelial keratoplasty: Descemet's stripping, endothelial keratoplasty, Descemet's membrane endothelial keratoplasty, pre-Descemet's membrane endothelial keratoplasty. So in the developing countries, endothelial decompensation post-ocular surgery is the commonest commonest indication for the endothelial keratoplasty, and in the developed countries, corneal endothelial dystrophies are the commoner. Other indications are herpetic endothelitis or the rare causes like age-related corneal endothelial failure. These are the types of endothelial corneal dystrophy. Among them, the commonest is the Fuchs endothelial corneal dystrophy. Then others are posterior polymorphous corneal dystrophy, congenital hereditary endothelial corneal dystrophy, X-linked endothelial corneal dystrophy. These are the pictorial presentation of the different endothelial dystrophies on the slit lamp examination. These are the different corneal transplant techniques for the endothelial disorder. In the penetrating keratoplasties, the full thickness corneal button is transplanted. As we evaluate, go further, the lamellar endothelial keratoplasty come in picture, and in the Descemet and DSEC we transplant the endothelium, Descemet's membrane along with the some layer of the stroma, and in the DMAC only endothelium and the Descemet's membrane is transplant. These are the post-op pictures of penetrating keratoplasty and the endothelial keratoplasty. Endothelial keratoplasties have some advantage over the PK. Tectonic stability is better in the endothelial keratoplasty. Suture related astigmatism is lesser. Rejection risk is less, and as it is not the open sky procedure, so the expulsive hemorrhage risk is also lesser in the EK, and the fast visual recovery. And why from DSEC to DMAC? So the anatomically it is more natural, lesser risk of rejection, better visual quality, and the faster recovery. These are some points that we can we evaluate pre-op the corneal status of the patient and the ocular comorbidities. On the basis of result of these findings, we decide the proper technique. These are some some points that you should keep in mind that can affect your results after surgery: the graft quality, graft preparation techniques, graft insertion, graft centration, and the surgical complication. Post-operatively, you should closely monitor the patient for the following points: graft attachment, because the common early complication of the surgery is the graft detachment. IOP should be measured because it can increase the IOP post-surgery. Endothelial function should be checked. Interface opacity should be looked for because it is the earliest sign of the graft failure. Graft thickness should be measured. Long-term patient can complain with the following complication: that the refractive error, endothelial resection, or endothelial failure. Thank you.
Thank you, Dr. Zeba. So that was the last presentation of the session, and we are very thankful to our esteemed judges that they have given us their valuable time and evaluated all the presentation critically. I would request all the presenters to come forward, and we'll have a group photo.
An audience. Now we start our session, that is non-competitive free paper session. First, I will like to invite Dr. Ravina Verma. Thank you.
Good afternoon, everyone. Myself, Dr. Ravina Verma. I am here to present topic on evaluation of dry eye status in diabetic patients with and without diabetic retinopathy changes. Dry eye disease. It is a multifactorial disease which leads to ocular surface inflammation, which in turn leads to increased osmolarity of the tear film, and tear film instability leads to visual disturbance and discomfort. There are various etiologies of dry eye, including autoimmunity, hormonal imbalance, systemic diseases, hereditary disease, nerve damage, etc. Now, what is diabetes and dry eye disease? According to various studies, the prevalence of dry eye disease in diabetes is 54%. The severity of dry eye disease increases with age and the duration of diabetes mellitus. In diabetes, due to hyperglycemia, it leads to decreased insulin hormone, microvasculopathy, diabetic neuropathy, which in turn leads to lacrimal functional unit dysfunction, abnormal tear dynamics, tear film dysfunction. Now, the aim and objective of the study was to evaluate the dry eye status in diabetic patients and the association between dry eyes and the diabetic retinopathy. The study was a hospital-based and cross-sectional observational study. The study population included was patients of type 2 diabetes mellitus, age more than 40 years, and the patient with and without diabetic retinopathy changes. The study population was divided into two groups, Group A and Group B. Group A include patients with clinical evidence of diabetic retinopathy, and Group B includes patients without clinical evidence of diabetic retinopathy. Exclusion criteria are patient on any other systemic medications like antihistaminics, oral contraceptives, antidepressants, or patients having any systemic and any other local diseases, contact lens users, and the patient who had undergone LASIK or any intraocular surgeries. Methodology. It includes, first of all, detailed general physical and clinical systemic examination of all patients, detailed ocular examination, tear film evaluation test, and McMoney's dry eye questionnaires. The tear film test includes the Schirmer's basic secretion test, tear film breakup time test, Rose Bengal dye test, and the Lissamine green dye test. This is the McMoney's dry eye questionnaires, include 12 questions. The scoring was done according to the age and the gender. This table, it shows that the clinical signs of dry eye in patients with diabetic retinopathy are more as compared to without diabetic retinopathy changes. The signs which were seen were the conjunctival vascular tortuosity, decreased normal corneal luster, and the fluorescence staining. The result, total 60 patients were studied, out of which 32 were males, 28 were females. 32 males में 14 patients were with diabetic retinopathy changes and 18 patients were without diabetic retinopathy, and in 28 females 16 were with diabetic retinopathy and 12 without diabetic retinopathy changes. The mean age of the patients were 57 to plus minus 9 years, and mean duration of diabetes was 6 plus minus 5.79 years. This table, it shows that patients with diabetic retinopathy, out of 30, only 12 patients show Schirmer test less than 10 mm, and TBUT in less than 10 seconds was shown by 24 out of 30 patients. And in patients without diabetic retinopathy, 3 out of 30 showed Schirmer test less than 10 mm, and 13 out of 30 showed TBUT less than 10 seconds. So the final result was, in population with diabetic retinopathy, around 36% patient show Schirmer test positive and 76 showed TBUT positive, and patients without diabetic retinopathy changes, around 13% show Schirmer test positive and 43% show TBUT positive. So we conclude that dry eye syndrome was positively correlated with the presence of diabetic retinopathy in this study. Due to the multifactorial etiology and the high prevalence of dry eye in patients with diabetics, diabetic clinics must include routine dry eye screening using the questionnaires, and the management of dry eye needs to be incorporated in the wholesome approach of treating a diabetic patient, in addition to the adequate glycemic control and management of diabetic retinopathy. Thank you.
Thank you, doctor. Any questions from audience? Please.
Did you include any other comorbidities existing diabetes के साथ में जो होती हैं?
No, ma'am.
Because there is a very strong association of
hypertensive and diabetic patients,
especially hypothyroidism. Hypothyroidism is very common with diabetes, and
but
if
I
you don't
included
include
only,
that, that will be a big confounding factor. और आपने ग्रेड भी किया था कि माइल्ड मॉडरेट सीवियर डायबिटिक रेटिनोपैथी को, बट इसमें तो आपने है और नहीं, you have taken only into consideration.
But according to grading, their patients were very less, ma'am. So
okay, the number of patients is less, but comorbidities is very important.
Yes, sir. Yes, sir. Yes, sir. According, higher grade type, grade 3 and grade 4 diabetic retinopathy shows higher dry eye symptoms. Reason,
Okay. Thank you, Ravina. Please collect your certificate. Our next speaker is Dr. Sakshi Mittal.
Hello, good afternoon everyone. My topic of presentation is prospective study of various factors leading to lens-induced glaucoma and visual outcome following its management. Introduction. Cataract and glaucoma are the major cause of blindness across the world, especially in developing countries. In India, it is a major cause of blindness, accounting for approximately 66.2% of cases in population more than 50 years of age, while glaucoma accounts for 5.5% of cases. Lens-induced glaucoma secondary to hypermature cataract is an important cause of secondary glaucoma. It is an important cause of morbidity and significant visual impairment. Preoperative and postoperative morbidity is more in an eye with lens-induced glaucoma than that with a simple uncomplicated cataract. Hence, timely intervention is important. The study was conducted on 40 patients of LIG who presented to our Department of Ophthalmology, R&T Medical College, Udaipur. Detailed ocular and systemic examination was done. Clinical diagnosis of phacomorphic and faculatic glaucoma was made. Patients who were diagnosed as lens-induced glaucoma or referred to us with diagnosis of lens-induced glaucoma and medically treated elsewhere are included in our study, and patients with a primary open or closed angle glaucoma or secondary glaucoma due to other causes are excluded. Medical management was done to bring down the raised intraocular pressure. The manual small incision cataract surgery was done. Postoperative evaluation was done on the next day, and patients were followed up on day 3, 7 at 1 month, and visual acuity assessment was done. Following results were derived. Total number of patients were 40, in which 39 patients had phacomorphic glaucoma, while only 1 patient presented with phacolytic glaucoma. Majority of the patients were in age group of 61 to 70 years of age. Majority of the patients presented with 6 to 10 days of onset of symptoms. 80% of patients had prior history of defective vision in affected eye for more than 1 month duration. 85% had PL positive and PR accurate, while 6 patients had PR inaccurate. Preoperative IOP levels, 17 patients had IOP in the range of 30 to 40 mm of Hg, while 4 patients presented with IOP more than 50 mm of Hg. Main reason for the delayed presentation was no attendant. Intraoperative complication in the form of PCR with vitreous loss was found in 12.82%, while zonular dialysis was found in 7.69%. Postoperative complication in the form of AC reaction and flare was present in 18 patients. Best corrected visual acuity at 1 month is poor in majority of the cases, with most of the patients at final visual acuity poor than 6/18. Discussion. In our study, phacomorphic glaucoma was more common than phacolytic glaucoma, similar to the study noted by the Madurai and Lahan study. Majority of the patients presented with defective vision of more than 1 month duration. Correlation between the height of the IOP and the visual outcome was clinically significant but statistically not significant, and the similar results were noted in the study of Velayutham et al. And study by Prasna et al. The main reason for the delayed presentation of the case were 50% had no attendant. A corrected visual acuity of 6/12 or better was taken at good visual acuity, and accordingly 20% of cases only get postoperative good visual acuity, while 80% had poor visual recovery. A strong correlation between the duration of attack and final visual acuity was found. The patient who presented early had significant good visual acuity postoperatively. Finally, we conclude that the main reason for the delayed presentation is no escort followed by the ignored symptoms. This implies the education of the patients regarding early presentation with decrease of vision and not to wait till the cataract is mature. Thank you.
Thank you, doctor. Please collect your certificate from Dr. Arvind Chauhan. And our next speaker is Dr. Sana Qureshi.
Good afternoon, everyone. My topic of presentation to study retinal nerve fiber layer changes in glaucoma on SDOCT, that is spectral domain or optical coherence tomography, correlate with visual field changes in perimetry. Glaucoma is a multifactorial optic neuropathy. It involves the gradual neurodegeneration of retinal ganglion cells and the axons that connect them. As a consequences of this, RNFL has become thinner and there has been an irreversible reduction in visual field. The extent of RNFL involvement is determined by SDOCT. This makes it possible to estimate retinal ganglion cell, accurately reflect the number of axons present in the nerve. The perimetry is used as a baseline and diagnosis as well as for monitoring of the disease. It classifies glaucoma into various stages, that is mild, moderate, severe. The visual field defect are found after the 25 to 30% of retinal ganglion cell loss, which may lead to patient with early glaucomatous damage remain undetected. The normal IOP range is from 11 to 21 mm of Hg for about 40 years of age patient, and the upper range for 70 years is 23 mm of Hg. Aim of my study is to assess retinal nerve fiber layer thickness and determine preferential involvement of different sectors of peripapillary RNFL using SDOCT and compare with visual field changes with standard automated perimetry in glaucoma. It is hospital-based, non-interventional, cross-sectional study. The sample size was 40 patients. Inclusion criteria are the patient with suspicious optic disc changes, that is CDR is more than 0.5, asymmetry between the two discs, that is more than 0.2, and primary open angle glaucoma, acute exfoliative glaucoma, and primary angle closure glaucoma. Exclusion criteria are anterior chamber congenital anomaly, corneal opacity and scarring, that prevent the appropriate OCT scanning. Severe NPDR and proliferative diabetic retinopathy. Patient have a visual field loss as a result of non-glucomatous disease. Neurological lesion causing optic nerve and chiasmal compression can produce visual field defect. Primary angle closure suspect, primary angle closure, neovascular glaucoma, and steroid-induced glaucoma. As a patient come to the hospital, we check vision, slit lamp examination, IOP by non-contact tonometer, pachymetry, fundus examination by 10D, 90D lens, gonioscopy, SD-OCT that measures to 3.5 mm diameter of optic nerve head, visual field testing. The acceptable visual field test includes false positive and false negative of less than 33% and fixation loss of less than 20%. Eyes are classified as having mild, moderate, severe glaucoma using Anderson criteria. The instruments used in a examination of the patient. Observation: 40 patients with 69 eyes are with established glaucoma were included in this study. There is no significant difference in age and sex distribution among the three glaucomatous groups. That is mild glaucoma eyes, that is 20 eyes total, 13 eyes of moderate glaucoma and 36 eyes of severe glaucoma. As the glaucoma progresses, CCT progressively decreases and IOP raises as the severity with the glaucoma. It is the age and sex distribution that shows the maximum group of patients is between 31 to 60 years of age. The mean RNFL thickness that shows the temporal quadrant is the thinnest quadrant and inferior quadrant is the thickest quadrant in a normal patient, and it shows maximum decrease in RNFL value. The graphical representation of retinal nerve fiber layer thickness in microns is the mean RNFL loss, that is inferior temporal quadrant and inferior nasal quadrant can be monitored for progression of glaucoma. That these two quadrants show maximum loss in retinal nerve fiber layers as the glaucoma proceeds. Compared with visual field parameters in glaucoma, that is in a mild cases, visual field index is 95 plus minus 5, in a moderate that is 75 plus minus 5, and severe that is 55 plus minus 5. In a MD and PSD, that shows as the glaucoma progresses, the MD is decreases and PSD is increases. Structural defect detection OCT correlates with functional defect on visual field. That is, the current study also compare the association of visual field defect with corresponding retina, that correlation of average RNFL measurement and visual field by the perimeter. The moderate is a photo showing moderate glaucoma patient with inferior temporal RNFL thinning corresponding superior nasal visual field loss in perimetry. This is the other photo that shows tunnel vision of severe glaucoma patient with generalized RNFL thinning. Result: the average RNFL loss in mild, moderate, and severe glaucoma is 25, 30, and 45% respectively. The difference in RNFL thickness between mild, moderate, and severe glaucoma in a different quadrant, that significant implies that susceptibility of each sectors to glaucomatous damage differs with stages of the disease. The temporal quadrant, inferior temporal and the inferior nasal sectors can be monitored for progression in the glaucoma patient, as these sectors show significant difference in RNFL loss, especially between the mild and the severe perimetric stages. Conclusion: pre-perimetric RNFL thickness is a useful measure to discriminate between mild and severe stages of the glaucoma. The inferior temporal sectors followed by inferior nasal show most susceptible to glaucomatous damage. The RNFL thickness in these sectors can be used to diagnose early stages of the disease. This study also helps to find the inferior and the superior quadrant of OCT measure RNFL thickness has close relation to the glaucoma and shows good association of visual field defect with corresponding RNFL thinning. Thank you.
Thank you. Please collect your certificate from Dr. Sumit. Next speaker is Dr. Sharath. Okay. Dr. Siddhi.
Good afternoon. The topic of my study is a study to compare the effectiveness of timolol 0.5% versus bromomidine 0.2% for control of rise in intraocular pressure after Nd:YAG laser capsulotomy. Introduction. Posterior capsular obfuscation (PCO) is the most frequently occurring complication of extracapsular cataract surgery techniques, including phacoemulsification and small incision cataract surgery. It is the most common cause of diminished postoperative vision. Posterior capsular obfuscation is caused by proliferation of epithelial cells of lens, which leads to fibrotic changes and crumpling of the posterior capsule. Nd:YAG laser capsulotomy is considered as standard treatment for PCO and has been found to be an effective method. Acute but transient rise in IOP is a frequent complication of Nd:YAG laser capsulotomy. Materials and method. The study was done on 80 patients, one of each patient with PCO planned for Nd:YAG laser capsulotomy. Patient of age group 45 to 70 of both genders with non-glaucomatous eyes, vision less than 6/24, and cataract surgery with PCOIL within 6 to 12 months were included. Patients with history of surgery for traumatic cataract, pseudo-exfoliation, pigmented glaucoma, open or close angle glaucoma, uveitis, and prior use of corticosteroids for long term were excluded from the study. The selected patients were divided into two groups of 40 each. The baseline IOP of all the patients was measured by appellation tonometer before installation of eye drops. Groups X instilled 1 drop of timolol 0.5% and group Y instilled 1 drop of bromomidine 0.2% 1 hour before capsulotomy. Topical anesthetic eye drop was instilled 1 drop 1 to 2 times about 2 to 3 minutes before Nd:YAG laser. The total amount of energy used in YAG laser capsulotomy procedure was recorded as viewed on the control display panel of Nd:YAG laser machine. IOP was noted 1 and 4 hours after the laser procedure. Result: a total of 40 patients were selected in each group. The mean age was 57 in group X and 58 in group Y. The baseline IOP was 16 for group X and 15 for group Y. There was no statistically significant reduction between the two groups in the mean IOP changes at 1 hour after Nd:YAG laser capsulotomy, but after 4 hours, the mean reduction in IOP was 1.5 mmHg for group X and 1.8 for group Y. Discussion. PCO is one of the most frequently visual disabling complications of cataract surgery. Nd:YAG laser capsulotomy is standard treatment for PCO. Although non-invasive and good safety profile, capsulotomy many complications can occur after Nd:YAG capsulotomy, like acute rise in IOP, IOL damage, uveitis, subluxation of IOL, and even cystoid macular edema. The most important complication of PCO posterior capsulotomy is increased IOP because raised IOP may have damaging effects to optic nerve, especially if it is already susceptible or compromised. It has been reported in severe studies that that rise in IOP generally reaches its peak within first 3 hours after laser treatment. Many IOP lowering agents have been tried to decrease the incidence and severity of IOP rise in Nd:YAG laser capsulotomy with varying degree of success. Timolol is non-selective beta blocker that lowers IOP by reducing aqueous humor production. Its time of onset of action is 20 minutes of administration and lasts for at least 24 hours with peak action at 2 to 3 hours. Bromomidine is a selective alpha-2 adrenergic agonist which decreases IOP by reducing the aqueous humor production as well as enhancing the uveous scleral outflow. It has peak action of 3 to 4 hours and a baseline measurement in group A was 16 mm and in group B it was 15 mmHg. In timolol group, a slight increase in the mean IOP was seen at the end of first hour, but this value was compromised to the baseline difference was not statistically significant. IOP reduction was observed after 4 hours of the procedure and the difference was statistically significant when compared with baseline. Immobilizing group, slight increase in mean IOP and the end of first hour was observed, but when this was compared to the baseline IOP, the difference was not statistically significant. The IOP reduction was at 4 hours after laser procedure and the difference when compared from the baseline was statistically significant. Conclusion: the study revealed that both bromomidine and timolol were effective in preventing rise in IOP after capsulotomy when given as a single dose administration 1 hour before Nd:YAG laser capsulotomy. Moreover, considering the drugs are safe, topical bromomidine 0.2 may be considered to have better IOP lowering effect after Nd:YAG laser capsulotomy as compared to timolol 0.5%. Thank you.
Thank you, doctor. Please collect your certificate from Dr. Poonam Jain. Our next speaker is Dr. Soju MR. Whether she is present. Okay, sorry.
Good afternoon, everyone. Myself, Dr. Soju Emma. My topic of presentation is analysis of visual impairment patients attending for visual handicap certification. Blindness has been recognized as an important public health problem in India. Blindness registers act as an important tool for public eye health programs used as data sources for population-based research, informed regarding different causes of visual impairment. According to a guideline by Ministry of Social Justice and Empowerment of Government of India, the minimum degree of disability should be 40% for an individual to be eligible for any concession or benefit. Materials and method. The study was conducted after taking an informed consent from patients or relatives in the Department of Ophthalmology, JLN Medical College, Ajmer, and after institutional ethical clearance. The sample size of the study was all the patients who applied for visual handicap certification, and it was a cross-sectional type of study. Study duration was about 6 months, and the sampling method was random sampling. And the inclusion criteria includes visual disability of 10% or above, case of visual impairment which were permanent in nature. Exclusion criteria includes remediable causes of blindness, temporary cause of visual impairment, and non-corrected visual acuity. Methodology. Patient fulfilling inclusion criteria were recruited into the study, and detailed history, clinical examination, and special investigations were done. Percentage of disability calculated, and certificate were analyzed to find out the various causes of visual handicap, demographic features of each individual. Results. Considering the age distribution, almost 68% were in the working age group, that is between 21 to 60 years, and 4% individuals were above 60 years of age, and 28% were below the age of 20. Considering sex distribution, 68% were males, 32% were females. Among us pediatric age group, 88.8 were male children and 11.12 were female children. The number of males were significantly higher than that of females in adult as well as in pediatric population. Then about the cause of visual disability, trauma was the most common cause which leads to phthisis bulbae, being present in about 32% of individuals, and optic atrophy was the second most common in 26%, which was followed by retinitis pigmentosa. Then about the reason for obtaining visual handicap certificate, about 40% need visual handicap certificate for educational benefits, 34% for pension benefits, 16% for travel benefits, and 10% for job benefits. Disability certificates such as those for blindness or visual handicap offer a lot of benefits to the recipient and help them to get reservation in colleges and jobs. They get travel concessions, income tax benefits, and disability allowances. People with disability percentage of 40 are considered as handicapped and entitled to government benefits. In our study, there was a male preponderance in application for certification similar to the study of Ambasta et al. In Bihar. That could be because of their traditional role of bread earners and more mobility in our society, and hence more need for employment and other benefits. High prevalence of phthisis bulbae caused by trauma in the younger population, which shows need of early intervention on certain occasions to prevent this disastrous condition in some cases. And also, early diagnosis and management is required to prevent blindness arising due to optic atrophy by various causes. Of all reasons, educational benefits was more common. Service and travel were next to it in younger age group. This suggests that the driving force to attend the board for disability certification was more among the younger age group, and this was probably due to presence of certain benefits associated with disability certification such as employment, education, traveling, and income tax benefits. So we conclude that data from applications for blindness certificate, apart from guiding in issuing them, provide valuable information regarding different causes of visual impairment that might otherwise not be certifiable but have an impact on the quality of life of the sight impaired. It can also provide an insight into the overall trends in disease profile and service delivery so that healthcare strategies can be planned and monitored. Thank you.
Thank you, Soju. Please collect your certificate. Next speaker is Dr. Somil.
A very good afternoon to everyone. Myself, Dr. Somil. I'll be presenting the study of normal anterior segment parameters using pentacam imaging technique in adult Indian population. The aim is to evaluate the normal anterior segment parameters using pentacam imaging technique. The introduction includes the measurement of the anterior chamber volume, which is useful for evaluating the anterior ocular segment topography in narrow angle is also done by pentacam. The integral calculus that is used to calculate the anterior chamber volume as a solid bounded by posterior surface of the cornea. That's 12 mm around the corneal vertex and the iris and the lens using the pentacam instruction manual. These are the various topographic maps depicting the normal findings of the cornea. The materials and methods are as follows. We utilize the Oculus pentacam. After taking the written informed consent, the study had 250 Indian volunteers, that's 500 eyes, who visited the ophthalmology outpatient department at the NIMS Medical College and Hospital, Jaipur. Every participant got a thorough ophthalmological and optometric examination, which included testing the visual acuity, having their eyes examined under a slit lamp, and having and under identical circumstances, ambient brightness. The tests were conducted using normal pupils. To eliminate the operator-related factors that may be confounded, the machine was employed in an automatic release mode. The participants were told to keep their eyes open for the entire 2 seconds duration while focusing on a black fixation object. To block off any light, a black cloth was placed on the subject's head. Randomly, the eyes were looked at. All the measurements were made between 9 a.m. to 2 p.m. and at least 4 hours after awakening, to prevent the known daily variations in the corneal thickness and other parameters. All the participants were guaranteed a minimum of 6 hours of sleep a night before. All the measurements were collected 3 times, and the mean of those results was taken into account. In the 250 left eyes and the 250 right eyes, the anterior chamber volume were noted and tallied individually. The inclusion criteria: the eyes were considered normal if they had no ocular pathology, no previous ocular surgery, and no irregular corneal pattern. The exclusion criteria included previous history of any previous eye trauma, corneal or intraocular surgery, glaucoma, corneal scarring, severe eye dryness, pregnancy or nursing, current corneal infections, use of topical medications, and those with soft contact lens user were included in the study after discontinuation of lens wear for at least 7 days. The parameters were derived from the topographic maps as shown prior. The parameters of the printout retained for the analysis were keratometry findings of the anterior and the posterior corneal surface, pachymetry, corneal volume, anterior chamber volume, angle and depth of the anterior chamber, topometric indices, data from the corneal thickness spatial profiles. The abbreviations for the parameters are used in this paper and they are explained in abbreviations. These are the results of the various abbreviations that are anterior chamber volume, anterior chamber depth, corneal volume, Kmax, total corneal thickness, axial corneal thickness, and central corneal thickness. And these are the graphs, histogram graphs depicting the increase in the central corneal thickness, and a certain decrease in the corneal volume, anterior chamber depth, and the other parameters. Thank you.
Thank you, Doctor Somil. Please collect your certificate from Dr. Poonam Jain. Any questions from the audience? अरे कुछ तो पूछ लो भाई, सब आता है, चलो ठीक है. Dr. Somita is our next speaker. Okay, fine. Okay, Dr. Sunil Vishnoi.
Good afternoon all. Today I will present on central macular thickness change after uneventful small incision cataract surgery and observational study. Introduction. Cataract surgery and its prevalence. Cataracts are leading global cause of preventable blindness. Cataract surgery is the most commonly performed ophthalmic procedure. Complication of cataract surgery. Cystoid macular edema is a potential complication after uneventful cataract surgery. CME can lead to vision deterioration if not properly managed. SICS is a preferred technique, especially among beginners cataract surgeons, known for precision, effectiveness, short duration, minimal equipment requirement. CM in post-operative cataract surgery. CM is the most common cause of post-operative visual impairment after uncomplicated cataract surgery. Two forms of CME. Subclinical, there is no visual acuity reduction, and clinical form. The incidence of clinical form of CME after uneventful cataract surgery is 1.5%. Macular edema and overview. Macular edema and abnormal increase in fluid in the macula. Major etiology of pseudophakic CME, also called Irving-Gaines syndrome, is inflammation. Inflammation breaks the ocular barrier, leading to increased vascular permeability. Macular edema also occur in other eye conditions like diabetic retinopathy, ARMD, and venous occlusion. Diagnostic tool for CME. Traditional method includes slit lamp, biomicroscopy, indirect ophthalmoscopy, fundus imaging, and now there is a new tool, OCT. Emerging and crucial tool for assessing retinal disorder, including CME, allow precise and non-invasive measurement of macular thickness. Study objective. This study aims to use OCT to evaluate central macular thickness change following SICS. Highlight the significance of OCT as a diagnostic tool in assessing CME and its role in the post-cataract surgery care. Research methodology. Patient enrollment and preoperative evaluation. This prospective hospital-based observation study was conducted on 60 patients attending the ophthalmology outpatient department of our hospital with clinical diagnosis of cataract and willing for cataract surgery. Thorough perioperative assessment include best corrective visual acuity, slit lamp examination, intraocular pressure measurement, and dilated fundus examination using indirect ophthalmoscopy to exclude the pre-existing retinal pathology. Inclusion criteria: age group 45 to 75 years, age-related cataract of ingredients, eligibility for central macular thickness measurement by optical coherence tomography. Exclusion criteria: patient with history of uveitis, glaucoma, ocular trauma, and or ocular infection within the previous 3 months, pseudoexfoliation syndrome, history of intraocular surgery, retinal detachment, systemic disease, hypertension, diabetes, or cardiac blood disorders, benign prostatic hyperplasia which affect the pupil size. Physical constraints preventing the OCT examination, presence of media opacity including dense cataract. Surgical procedure: a small incision cataract surgery performed by a single experienced surgeon. Preoperative central macular thickness measured using OCT with a macular thickness protocol. Post-operative follow-up: patient follow-up at 1st week, 6th week, and 12th week post-operatively. Each visit includes the assessment of visual acuity, slit lamp, fundus examination, intraocular pressure, and central macular thickness were measured using OCT during each follow-up. Resultant observation: age and sex distribution. The age of the patient ranged between 45 to 75, with the mean age being 46 years, having 55.19% females and 44.81 males. Maximum number of patients were in age group of 56 to 60. Preoperative and postoperative best corrected visual acuity. Preoperative and postoperative best corrected visual acuity were recorded by Snellen visual acuity chart converted into decimals values. The preoperative mean best corrected visual acuity was found to be 0.06 plus minus 0.023, whereas the post-operative mean best corrected visual acuity was found to be 0.67 plus minus 0.18 at the 1st week, and at the 6th week 0.68 plus minus 0.18, and at 12th week 0.69 plus minus 0.18. Result observation contain macular thickness. The preoperative and postoperative mean macular thickness at different follow-up are mentioned in the graph. You can see in pre-op or after 6 weeks the maximum rise in the macular thickness, and which return to the normal at 12 week post-op. And these are the values. At pre-op 219.04 micrometer, 1 week at 2 to 4.0, or 6th week and 12th week. Maximum at the 6th week. Conclusion. Comparison between preoperative central macular thickness and postoperative central macular thickness after 1 week, 6 week, and 12th week suggests a significant correlation. A subclinical increase in macular thickness occur after uncomplicated surgery, having a peak by 6 weeks after surgery, which return to near normal by 12 week, postoperatively. OCT shows an increase in macular thickness without altering the architecture of the macula. There was no correlation established between the best corrective visualization and the macular edema postoperatively. Thank you.
Thank you, Dr. Sunil. Please collect your certificate. Dr. Somita.
Good afternoon, everyone. Today I'm giving a presentation on the clinical study of ocular manifestation in head injury. Introduction. Head injury is the most common cause of death and disability in trauma patient, and visual system is one of the system involved in the traumatic brain injury, because the eye has close proximity to the head, as well as there are neural connections between the eye and the brain. Ocular trauma is one of the most important preventable cause of blindness and visual impairment in the world. Eyeball is anatomically protected inside bony orbit socket, and orbital margins are covered entirely with the eyelid and lashes, and also they are embedded in the cushion of retrobulbar fat of pad behind. In spite of all of these, eye is very vulnerable to the injury. There are many theories are proposed how eye is injured in traumatic brain injury. In penetrating brain injury, there is physical damage to the visual pathway, visual cortex, and other vision-related structures of the brain. In non-penetrating or closed head injury, displacement, stretching and shearing forces are involved, which cause damage to the brain, including those associated with vision. Many of the ocular manifestations are often missed and present much later to the ophthalmology department. Hence, clinical correlation of the ophthalmology finding is very important in early localization of the site of injury, ongoing assessment, management, and prognosis with head injury. Patients and method. It was prospective analysis of 164 head injury patient which presented in MDM hospital from December to May, and ocular examination was followed in all these head injury patients. First of all, a clinical examination was done using torchlight, then visual acuity with Snellen chart, color vision with Ishihara chart, pupillary assessment, slit lamp examination whenever it was possible, fundus examination with direct and indirect ophthalmoscopy, B scan for any posterior segment pathology, X-ray and CT scan, gonioscopy and intraocular pressure measurement if required. Exclusion criteria were previous head injury of any patients, any congenital anomaly, unconscious patient who did not require adequate consciousness. Inclusion criteria were presenting for first time, unilateral, bilateral, all mode of injuries, all age groups, male or female. Results were among 164 head injury patients, most of them were males, 144 were males, and it included young age group 21 to 31 years. The leading cause of head injury was road traffic accident, then followed by assault and accident self-fall. Most frequent presentation was periorbital ecchymosis. Most frequent neuroophthalmic manifestation was traumatic optic neuropathy. Orbital fracture was seen in most of the patients. Out of the 164 head injury patient, it involved the sequence from outer to inner side. Lid was most frequently involved, then conjunctiva, then cornea, and then sclera. Anterior chamber manifestation was also seen. Pupilla and iris were also involved, and cranial involvement was seen in 144 cases, and orbital wall fracture was above 50%. Discussion. In our study, most of the patients were young adult male age group, which was similar to the previous study conducted. Also, in our study, periorbital ecchymosis was seen above 70%, which was in contrast to the other study, less than 50%. Periorbital edema was seen in 75% patients of our study, whereas in other study conducted by Samaji, it was 41.48%. Conclusion is ocular involvement is very common in head injury patient, and it should be carefully evaluated because it can save the life and sight of the patient, and road traffic accident related morbidity can be drastically reduced if we can precautionary measures. Thank you.
Thank you, doctor. In one study, it was mentioned that papilledema and sixth nerve palsy followed by pupillary size abnormalities were related with the grave outcome of head injury. Means in patients with papilledema and sixth nerve palsy, the mortality rate was maximum. So ocular science can be useful in also deciding the prognosis of the head injury sometimes. Thank you, doctor. Kindly collect your certificate from Dr. Poonam Jain. Our next speaker is Dr. Surbhi.
Good afternoon. My presentation topic is comparative study of fundus changes in hypertensive and normotensive pregnant females in third trimester of tertiary center. Introduction. Pregnancy-related hypertension is one of the leading causes of maternal and perinatal mortality worldwide. Hypertension in pregnancy is defined as a systolic blood pressure of 140 mmHg or higher and a diastolic blood pressure of 90 mmHg or higher, confirmed on at least 2 occasions of 4 to 6 hours apart within a week apart. Aim of study is comparison of fundus changes among the hypertensive and normotensive pregnant females in third trimester. The severity of hypertension has been linked to changes in the retinal vascular system. The progression of retinal vascular changes has been linked to the fetal mortality in numerous studies as a sign of increasing PIS severity. Retinal changes were graded according to the Keith and Wagner classification. Grade 1, mild generalized arterial attenuation, particularly of small branches. Grade 2, more severe grade 1 plus focal arterial attenuations. Grade 3, grade 2 plus hemorrhages, hard exudate cotton wool spots. Grade 4 is grade 3 with papilledema. One of the most dramatic and potential serious ocular complications of PIH is retinal detachment. Method. A cross-section study conducted in RNT Medical College attached to the government hospital, a tertiary care hospital in Udaipur. Inclusion criteria, all pregnant females about 28 weeks fulfilling the criteria of hypertension in pregnancy. Exclusion criteria, all pregnant females with pre-existing ocular disease and chronic renal disease. Method of data collection. Study group were divided into 2 groups. First group consisting of 50 normotensive pregnant females as control and 50 hypertensive pregnant female fulfilling the inclusion criteria in second group. Result. In this study group, nearly 58.33% of study group showed the fundal changes of grade 3. Most common fundal changes noted were arterial attenuation followed by hemorrhages and exudates in 52% and 26% respectively. 8 cases with deranged LFT had grade 3 retinal changes followed by 8 cases had grade 4 and 2 cases had grade 2. The most common grade was grade 3 retinopathy with deranged LFT, RFT and platelets. It was observed that of the patient preeclampsia without severe features, 48.6% has no retinopathy. Of the changes observed, grade 1 was most common, 28.6%. None of the patient has grade 4 changes. In the patient of preeclampsia with severe features, 100% cases had varying degree of retinopathy. The most common grade still being grade 1 to 41.66%. In the group of eclampsia also, 100% had some degree of retinopathy. Thus, as severity of disease increased, incidence of retinopathy also increased. Relationship of retinal grading with severity of PIH. 36% has a fundus grading normal, 30% has grade 1, 32% grade 2, 22% grade 2, 8% grade 3 and 2% grade 4. Discussion. The incidence of PIH is more common in primipara than multigravida because the young retinal arterioles are more sensitive to high blood pressure. The second high peak was seen in patients having multiple pregnancies. These findings were similar to Bakda et al. The incidence of PIH as well as positive fundus finding is more common in age group of 18 to 25 years. Our study correlates with the study of Nutra et al. Women under 20 years were 6 to 7 times more susceptible than those in age 25 to 29 years. 15 retinal detachment and papilledema are indicated for termination of pregnancy. The prevalence of hypertensive fundus changes was found to be 24%. This is little more than reported by Tadin et al. 17. The prevalence of ocular changes in PIH patient as described in literature varies from 30 to 100% who reported that. Discussion. Visual symptoms are generally not very frequent in patients of PIH. Out of the visual symptoms, blurred vision is most common followed by photopsia, scotoma and diplopia. In our study, we didn't come across any patient complaining of significant visual disturbances. Mild arterial spasm involving the bulbar conjunctival vessels has been observed in normal pregnancy. When the retinal hemorrhage are present, a more severe hypertensive state is suggested. The presence of retinal hemorrhage, transudate, or papilloedema associated with hypertension requires prompt interruption of pregnancy regardless of duration of gestation. The severity of preeclampsia correlate with the occurrence of retinal changes. 100% of patients with preeclampsia without severe features showed no changes on fundoscopy, while 88.9% cases of severe preeclampsia and eclampsia had positive findings. The presence of systolic blood pressure of 195 mmHg had 85.7% sensitivity and 93.1% specificity for predicting the presence of retinopathy. The area under the curve was significant 0.945 with p-value less than 0.001. Similar results have been reported by Tadin et al., who reported that the degree of retinopathy was directly proportional to the severity of preeclampsia. The ocular vascular changes in PIH have been found to correlate with the severity of hypertension, and this has been used as an indicator to predict adverse fetal-maternal outcome and for the termination of pregnancy. There was a significant correlation between the degree of proteinuria and retinopathy. Similarly, Sharma et al. Reported a significant association of severity of retinopathy with proteinuria, which was also in consortium with Tadin et al. Conclusion: the retina offer a non-invasive platform to directly observe the pathological changes occurring in the systemic vasculature. The retinal changes of grade 3 is more commonly noted in pregnant female diagnosed with hypertension. Hence, the eye can truly be considered a mirror to the otherwise elusive vascular changes occurring elsewhere in the body. Hence, we should offer the fundoscopy to all hypertensive females, pregnant females, so that if positive findings are noted, active intervention can be done correlating with the other radiological and biological findings. However, to achieve optimal result in management, synchronization of obstetrician with ophthalmologist should be considered, provided there is an adequate resource for conducting fundal examination alongside antenatal care. Thank you.
Thank you, Dr. Surbhi. Please collect your certificate from sir. And I request Dr. Vinish to come for his presentation.
Good afternoon. The topic is the etiological analysis of pale optic disc and its correlation with the visual outcome in patient attending a tertiary care hospital, SNMC Medical College, Jodhpur. The death of the retinal ganglion axon that comprises the optic nerve lead to the optic atrophy and giving the resultant picture of a pale optic nerve. The term optic atrophy describes a group of clinical conditions which have abnormal pallor of the disc as a common physical sign. Optic atrophy is not a disease. It and result any pathological process that damage the retinal ganglion cells and axons of retinogeniculate pathway. The axons of retinal ganglion cells make up the optic nerve and continue onto the optic chiasm, optic tract, and up to the little geniculate body where they synapse. Injury to the retinal ganglion cells and axon anywhere along their course from the retina to the little geniculate body may result in the optic atrophy. Clinically, optic atrophy is associated with decrease in the visual acuity and visual field defect. There are numerous causes of optic nerve damage anywhere along the path from the retina to the lateral geniculate. The etiological factor includes the intracranial tumors, meningitis, optic neuritis, toxic atrophy could lead to optical atrophy. The detailed clinical evaluation help in differential diagnosis and management of the optic atrophy. There are no specific treatment for optic atrophy itself. The underlying cause, whether inflammatory, ischemic, compressive, and metabolic, should be treated if known. The aim of the study is to analyze the etiology of pale optic disc and its correlation with the visual outcome over a period of 6 months follow-up. Objective of the study was to study the etiological pattern of the pale optic disc to correlate the etiological cause of the pale optic disc with visual outcome. Study was conducted at Department of Ophthalmology, Dr. SN Medical College, Jodhpur. This was a prospective observational study. A total of 50 patients with non-glaucomatous pale optic disc were included in the study. The detailed history, including the past medical history, was recorded. A comprehensive ophthalmological examination is done, including visual acuity, color vision, visual field defects, slit lamp biomicroscopy, ophthalmic examination, fundus photograph, contrast sensitivity, biochemical investigation, neuroimaging was ordered when indicated to identify the etiology, and patients were followed up over a period of 6 months for visual outcome. The main etiology observed for the pale optic disc among the study population was traumatic optic neuropathy. Majority of the study population were young adults, and observation of traumatic optic neuropathy may be attributed to their age group. Improvement of visual outcome was less in the study population when compared with the other similar studies. Best corrected visual acuity of at least one line improvement in Snellen chart after 6 months was observed in 34% of the study population, which was contributed to 16% by optic neuritis, 12% tumor, 3% trauma etiology. Hence, the visual acuity outcome can be concluded to be poor among the study population after treatment. These are the etiological wise disc pallor. Majority of comprises the traumatic optic neuropathy, 22% optic neuritis, 22% comprises tumor, and the rest are the primary optic atrophy, toxic and inflammatory and infectious causes. The conclusion: the definitive diagnosis of the optic disc-pallor, which itself is a sign of underlying disease, is very important. Identification of the actual cause of optic disc-pallor will help in its appropriate management. Patient presenting with pale optic disc with optic neuritis, tumor, trauma, etiology showed visual acuity of 1 line improvement in Snellen chart, where pale optic disc with other etiology shows no improvement in visual acuity over a period of 6 months. Pale optic disc may be threat to patient vision, and identifying the etiology can save patient vision and also associated underlying systemic cause by timely intervention. Moreover, further optic nerve damage can be halted by identifying the etiology and treating the cause. Thank you.
Thank you, Vinesh. Next presenter is, please collect your certificate, Dr. Vinesh.
Good afternoon, everyone. Here I am presenting an observational study to determine the association between posterior vitreous detachment and proliferative diabetic retinopathy. Introduction. Given that diabetic retinopathy stands as a prominent cause of blindness, consistent monitoring for its progression is imperative. Special attention should be paid to individuals with borderline severe non-proliferative disease, as early detection of PDR can prevent irreversible vision loss. During the assessment of progression, certain factors act as protective measure against PDR, with PVD being a significant factor. PVD serves as a scaffold for new blood vessel growth. When coupled with traction, can lead to complications such as vitreous hemorrhage, traction, RD, and neovascular glaucoma. Complete PVD acts as a safeguard against these complications in PDR. However, incomplete PVD carries a higher risk of PDR due to availability of scaffold for new vessels proliferation. This study investigated the relationship between PVD and PDR complication, providing insight for assessing further progression. Patient and methods. Study design. Non-randomized cross-sectional study, planned sample size 20 patients. We conducted this study with type 2 diabetic patient diagnosed with diabetic retinopathy who visited the outpatient department between February to September. Study period was for 8 months. Subject selection: we include a total of 20 type 2 diabetic patients with age 40 to 70 years who met the following inclusion and exclusion criteria. Inclusion criteria were type 2 diabetic patient with DR diabetic retinopathy, age between 40 to 70 years. Exclusion criteria: coexisting condition like hypertension, blood disorders, collagen vascular disorders, sarcoidosis, extreme refractive errors, and high axial length. Ocular comorbidities such as glaucoma and uveitis, previous retinal photocoagulation and intravitreal injection, history of trauma, intraocular surgeries, and electroconvulsive therapy. Exclusion of the carotid occlusive disease through physical examination, patient for whom fundus examination and FFA could not be performed. Result: in our study, we focused on individual between 40 to 70 years. We observed a correlation between age and PVD and determined that the mean age for PVD was 60 years. We found a positive correlation between the grading of posterior vitreous detachment and the severity of diabetic retinopathy and its associated complications. When considering the age group with a mean age of 60 years, 62% of the population comprised male and 54 and 70% experiencing higher grade of diabetic retinopathy in the right and left eyes respectively. Among them, 55% exhibited posterior vitreous detachment with 44% having complete PVD. Discussion. So in this study, PVD and its association with complication of PDR has been elicited, which gave result for assessing further progression. In our study, we had taken 150 patients with proliferative diabetic retinopathy classified based on the EDTRS classification. Discussion continue. Purpose of the study was, by comparing the grading of the posterior vitreous detachment in diabetic retinopathy, we have arrived that 50 patients with PDR, 48% had complete PVD in right eye and 40% in left eye, in which the grading is mild to moderate grade of diabetic retinopathy with a significant p-value of less than 0.001, high positive correlation. Conclusion. Our study reveals a positive correlation indicating that patients with complete PVD experiencing fewer complications from proliferative diabetic retinopathy and enjoy better vision compared to the patient without posterior vitreous detachment or partial vitreous detachment. Thank you.
Thank you, doctor. Kindly collect your certificate from Dr. Poonam Jain. With this, we conclude our session. Thanks for your participation and patience. Thank you very much.